Happy Sunday. Let's start with the obligatory back of the net. Hope you're all having a good Sunday. It is Sunday, right? Yeah, it is Sunday. You'll all be incredibly relieved to know that I am back to full health. My hay fever is gone for now. I'm not sure why it's so much better this morning, but there you go. It is. So I am not a sniffling mess as I was yesterday. So that's always good. Those of you that saw yesterday's stream will know I had to dart out early because I was so snotty and sniffly and disgusting. Shame on me. But I'm back in full effect. Don't call it a comeback. And I'm going to finish off watching Matt Hancock's juicy evidence to the committee, which I've already watched some of, and the answers have already been okay. He hasn't really done much in the way of darting out of the way of questions in anything that was too ridiculous. The one evasion of the question, which was incredibly embarrassing, was this. And I'll try and find it now. He coined a phrase I haven't heard before. Let me see if I can quickly find it here on the stream.
Because you will get a set of false negative results. And secondly, that when you only have a relatively small testing capacity compared to, say,
so he's being asked about why Curvo Bianco Nero. How's it going? How's your day going or night going? If you're in the US, thanks for joining. I like that emoji, by the way. I don't know what that is. Is that a custom one? He's being asked here about. Matt Hancock says that he was very aware of how they handled the pandemic in Taiwan and South Korea, and the fact that that went so well, and he was completely aware of this, yet he failed to tell anybody that he was working with. And Jeremy Hunt, who is one of the two people questioning him at the moment, asks him, why didn't you tell anybody this? And why was it not given to you as advice by SAGE, the health committee that monitors and oversees all of this stuff to do with the pandemic? And these are his answers. And I'm trying to find the one that was particularly maddening in its evasiveness.
One is that the need for a rapidly scalable testing operation. If you think about the areas where we were strong in our response to the pandemic, they're areas where we had prior strengths. So the NHS care to everybody who needed it. We didn't have a major diagnostics industry or capability, and the tracing and isolation system was essentially built for very important but very small outbreaks. As Health Secretary, you're dealing with these sorts of outbreaks all of the time. I'm currently dealing with a monkeypox outbreak and an outbreak of cases of drug-resistant TB, and that is absolutely standard. And the lack of that capability at the start meant that
I kind of found
the
that
options that we had were few.
That idea of dealing with outbreaks all the time, monkeypox, kind of seems like he's throwing it out there as almost like a I've dealt with more pandemics than you've had Sunday lunches, mate, kind of comment. Just kind of throw everybody off the scent. COVID, it's nothing. Forget about it, mate. I'll eat COVID for breakfast. I'm still trying to find this answer.
But to 100,000 a day, that was a big change.
Yeah.
If you had been advised in January or February, we're going to need more testing capacity if we want to go South Korea.
So I don't think that's...
And let's start this right away.
But we did. So we did. In January, I was driving the system to drive up testing capacity. In fact, in preparation for this meeting, I was looking at the minutes of one of our internal meetings on the 27th of January when I was calling for the driving up of testing capacity. And PHE's response was excellent on the science, but there was simply not the experience to drive up capacity. And so when we got to 2,000 a day by the end of February, and it was still rising, but by the middle of March, it was not rising fast enough.
I might watch
we were
this,
not doing enough
James
to bring in
O'Brien
the private
reacts
sector
to boring
capacity,
words
so I
between
took
Hancock
personal
and
charge of it,
Dominic.
and then a couple of weeks later set the 100,000 target. And that 100,000 target was essential in galvanising the whole system and building a diagnostics organisation and ecosystem in this country. And now we do about 6 million tests
And that was
a
a
week.
very important step in our pandemic response. But the strategy at the time was clear that when we got through stage 1, community testing would stop. Now, on the 16th of March, when Dr. Tedros said we needed to test, it was a week after we'd stopped community testing. Did you challenge officials and say, why do we appear to be doing something that is completely different to what the World Health Organization is advising?
I entirely agreed with Dr. Tedros at that point. And the challenge, though, was the scale of the capacity. And I'd driven that as hard as I could within PHE, with my indirect, therefore.
Oh. Oh, come on. Apologies, folks. That's me having too many things open at once. Come on, sort it out. Yes, this is the answer that I was.
The strategy at the time was clear that
yesterday.
when we got through stage 1,
the day before yesterday, should I say?
Community testing would stop. Now, on the 16th of March, when Dr. Tedros said we needed to test, it was a week after we'd stopped community testing. Did you challenge officials and say, why do we appear to be doing something that is completely different to what the World Health Organization is advising?
I entirely agreed with Dr. Tedros at that point. And the challenge, though, was the scale of the capacity. And I'd driven that as hard as I could within PHE, with my indirect, therefore, hands on the levers. And then in the middle of March, we had a meeting, I remember it very clearly, we had a meeting in Downing Street at which we had an array of the test providers.
Who talks like that? Absolute evasive bullshit. That makes I did not have sex with that woman look like the most direct answer in the world. Right, anyway, skip ahead a bit because we have done all this.
That are taken in my name as Secretary.
I'll try and carry on from where I was the other day.
State across the health.
I'm going to watch all 4 hours. Don't be worried about that. I'm going to try and skim the boring shit if there is any. Maybe it's all going to be good. Maybe it's all me.
Family in the NHS, Public Health England, in the department. And I know the Prime Minister feels very strongly the same. But of course you're guided by the science.
So just looking forward, my last question on this area, how do we improve the quality and the diversity of the advice going to ministers from SAGE and the scientists in the future? Do you think there would be merit, for example, in a pandemic situation rather than normal times, in publishing that advice immediately so that you get the benefit of instant peer review from the entire scientific community?
Yes, and now thankfully we do publish the evidence now, and the minutes of those meetings, and I think that the public debate around this is generally healthy.
Thank you.
Thank you. Just in terms of following up Jeremy's question about career, The Science and Technology Committee in March took evidence from Public Health England, and one of the officials there said an evaluation had been made, a formal evaluation of the South Korean model, as to whether we could learn lessons from it in that early phase of the pandemic. But try as we might, that paper seemed to have evaporated. It disappeared. It's never been produced to us. Did you ever see it?
I have no recollection of that. That's not to say no, because actually in prepping for this committee, I've gone through a whole load of this, and there's some things I've discovered that I'd forgotten that I did. And so it's not a no, but I have no recollection of it.
All right. And just on the 100,000 target that you set when you'd gripped the problems that you saw, that was the subject of again some quite bitter criticism from Dominic Cummings. He said it was criminal that you should have set that target, and it was notable during that time. Again, the Science and Technology Committee took evidence, and no one that came before us, including your officials, wanted to associate themselves with the target. Even your testing czar, John Newton, when we asked him what was the derivation of the 100,000, said we'd have to ask the Secretary of State. It was his target.
It was my target.
So, but evidently, why was it the case that even your advisors and the whole of Whitehall seemed to be running away from it and not wanting to associate themselves with it?
Well, I think I don't know whether the testimony you're talking about was before or after we hit the target.
Before.
Before. Well, there you go. So
just explain what's in your mind there.
Well, we didn't know we were going to hit it, and sometimes you have to put yourself in jeopardy. You put yourself on the line. And in this case, I knew we needed a radical increase in the testing capacity, a radical increase, and the incremental increases would not do. And so
he promised something he knew there was a large risk that he wouldn't be able to deliver.
So I set the 100,000 target, and I set it on the advice of my team who were doing the ramp up. I asked them what's the best they could do by the end of the month. The advice they gave me was just over 100,000, but 100,000 is a good number for a big target. And the purpose of the target was to galvanise the system, and it worked. And if you ask anybody involved, including many of those who've been mentioned during this select committee process, they will say that the 100,000 target mattered because it galvanised the system, not just in the government, but the whole country. We needed diagnostics companies to come to the table. We needed the NHS labs to step up further and expand. And it said to everybody, we are going for it big time. And it worked. Now, within government, the whole of the department involved in testing was focused on the goal. And I'm delighted to say that we hit it. Now, there were others. It turns out I had no idea at the time that there were others who were working, who were not as supportive as I might have hoped.
You didn't know that Dominic Cummings, for example, at number 10,
I knew that
as far as he spoke for them, was against the whole enterprise of 100,000.
Well, I was a bit surprised by the testimony that he didn't think that we should have a target or that we shouldn't. Anyway, I was a bit surprised by the testimony. You didn't know at the time.
That hadn't been communicated to you at the time.
No, and I'll tell you why. Because what I was just coming on to, the Prime Minister was absolutely foursquare behind me and gave me his full, wholehearted support in hitting the target. Because he, like me, knew that we needed a radical increase in testing, and it is a tried and tested method. In fact, it turned out afterwards, I was told that this is an absolutely standard business school methodology. I've never been to business school, but it turns out you set a big goal, you galvanise the team, you give everybody confidence just to do what is needed to build this capacity, and it worked. And I also saw some testimony from some people saying, we needed to get to a higher number. Well, absolutely, but you can't get to a higher number without going through the lower number first, and this is what we did.
Okay, Laura Shott.
Thank you, Chair. Good morning, Dominic Cummings said on the 25th of January that he contacted you about pandemic preparedness. And you said to him, we've got 4 plans up to and including pandemic levels regularly prepped and refreshed. CMOs and epidemiologists. We are stress testing now. It is our top tier risk register. Is that your recollection of what you said? And with hindsight, what are your thoughts on the level of pandemic preparedness that was in place at that time?
Yes, I think the record is actually slightly wrong because I said, well, that's all correct except I said the CMO is an epidemiologist.
Okay.
But the question was, are we ready for something like Ebola or a flu pandemic? And famously, the preparations and the plans that were in place were for a flu pandemic. Now, the honest truth is that this was a completely novel virus, and in fact, as we'll come to when we talk about asymptomatic transmission, it's different even from the previous coronaviruses, including SARS and MERS. So it's true that the countries that experienced SARS and MERS were better prepared than we were, partly because of that experience. But it is also true that COVID-19 is very different from SARS and MERS, and the number one difference is that it has asymptomatic transmission.
But that doesn't mean that it's not important that those other countries were more prepared. So you can't wash over it by saying that COVID is different, because even though the virus is different from SARS and MERS, Taiwan and South Korea still did much better than the UK in every regard, even though it was different. So you could have taken those learnings and done as well as them.
Those plans that were in place, the flu preparedness plans, they were incredibly useful in some areas. They meant that we had a draft bill, which became the Coronavirus Act. It meant that we had plans ready for infection prevention and control. And in fact, we published our first infection prevention control data and guidance, guidance, on the 10th of January. So those plans were important. But of course, when you have a novel pathogen, it behaves differently to what any plans could possibly set out. And what really mattered is the capabilities that we had. And there were some areas where we had strong capabilities, as I said to the chair a moment ago. There's some areas like the NHS, like science, where we had strong capabilities. There's other areas where we had weak capabilities, especially testing. And also on a vaccine, that's a big difference with flu preparedness, because we had vaccines ready to go on flu, and we've got antivirals. We've still got a big stock of them. But for a coronavirus, there was no vaccine, and there aren't any proven antivirals either. So what I said is absolutely true in response to the question. He asked me, are we ready for Ebola or a flu pandemic? And I said we have full plans for those things. But of course, at that time, 25th of January, in the department, we were working incredibly hard on responding not just to Ebola or a flu pandemic, but responding to what we knew of what became COVID-19.
And how many of those deficiencies were predictable? So do you think we should have learnt more from SARS and MERS? And do you think that the lack of diagnostic testing was a predictable failure that we should have addressed pre-pandemic?
It's a very good question. Some of these things we would have done better to have learned from SARS and MERS. Other things weren't predictable. So, for instance, I first asked for started the push for a vaccine in January. And in fact, I had a meeting on the 25th of January pushing for a vaccine, in which I was told that it would take a long time, that it would take normally 5 years, and typically if we accelerated everything and if everything went right, it would take a year to 18 months. And I said, I want one within a year, and we will throw the full resources of the state at making that happen. And we tasked Jonathan Van Tam with leading that project, and it was obviously hugely successful. Now, so it was predictable that we didn't have a vaccine for a coronavirus, And so as soon as we knew this was a coronavirus, which was relatively early in January, we knew that the gap in the vaccine armoury would be a significant gap. There's other things that were far harder to predict.
And in terms of, if you think about the function for pandemic preparedness, if we're trying to make changes in the future,
Yes.
do you have any reflections on things that we should do to make sure
Yes.
those predictable deficits are fixed
Yes,
for next time round?
absolutely. So we need a standing testing capacity so that we can stand it up immediately. We need an at-scale contact tracing capacity so that we can contact trace even when the numbers get big. Because the reason that community contact tracing stopped was because the number of infections was so big, and the capacity, again, as with the other PHE capacities on the way into this, were great on the science and small scale, but couldn't scale. So we need in good times to retain a capacity so that as and when a new pathogen hits that could become a pandemic, we are ready to pounce on it. I think another huge learning point is borders. I don't know whether we'll come on to that later, but on borders, the position that we took was based not just on World Health Organization advice, but on their international health regulations, which stipulate that closing borders is not an appropriate response in a pandemic. That is the international regulation. Now, the advice that we received, the clinical advice we received, is that unilaterally taking action at the borders would only have a small effect in terms of delaying the response of about a week. And indeed, early in the pandemic, this was proven by both the United States and Italy taking direct action at the border, and they still had the disease went rife. But if everybody takes action on their borders and restricts movement, then clearly that can have a big impact. And so we've strengthened our border policy throughout, and now we have one of the strongest borders policy in the world. But my reflection on it at the time, and this is very important for the lessons learned, is that the only way the world could have stopped this virus getting out of China is if China itself had stopped people leaving China. Because as soon as people were allowed to leave China to go to one place, then unless the whole world took action on borders, as they have now, it would only have delayed to a degree. That was the clear clinical advice, and it is one of the things that we absolutely must change at the global level, that part of the response to a dangerous pathogen needs to be health action at the border.
Thank you, Secretary. Thank you, Chair.
Thank you. Rebecca Long-Bailey.
Thank you. Mr. Hancock, you've said that testing was at no point scaled down. You were ramping up testing capacity all the way through.
For those that don't know, this is Rebecca Long-Bailey, a Labour MP.
And that you wanted to scale that up certainly in February, but that you had to prioritise testing. So just before the first lockdown, what was the plan for the prioritisation of testing?
Yes, this is important. I think it was published, but if not, I will write to the committee with the full clinical details. So this was a clinical document that set out the prioritisation according to what use of tests is most likely to save lives. And if I recall correctly, the top item was use of tests in intensive care, because in intensive care, if somebody has breathing difficulties, the difference between knowing that this is COVID-19 or not can be a life-saving difference. So if you start with intensive care and then work through, but it was a clinical prioritisation.
Thank you. A whistleblower reportedly stated to the media yesterday that in March 2020, Public Health England's internal advice was to ensure that any patients newly discharged into care homes had to be tested for COVID-19. Now, the whistleblower allegedly says that this initial advice was signed off by two PHE officials, Dr. Eamon Moore, Director of Health and Justice, and Dr. Julia Byrne, Head of Clinical Epidemiology, and that was the case up to the period just before the first lockdown. Would you say that was correct?
I have no recollection of that. That is not my recollection of the clinical advice, and I haven't seen anything on that.
Well, the whistleblower goes on to say that even though officials were fully aware of COVID-19 outbreaks in care homes at this time, allegedly one of your health ministers leaned on Public Health England to alter the advice being published because your department believed that they needed to empty space and get people out of hospitals. And the whistleblower says that Dr. O'More and Dr. Byrne were therefore pressured to sign off on published guidance that was softened to allow care homes more freedom to take residents in. So was discharge testing advice softened at the instruction of your department?
So that'd be pretty big, because you can't just change the guidance of something because you've got no space here and more space there, and say that you can't say that black is white and white is black because you want to manage capacity, unless you say we want to manage capacity, so this. But this whistleblower is saying that the reality was very different from what was actually happening with the advice.
I'm aware of. If I can set out the clinical advice that we were given, because we followed the clinical advice throughout on this, and it's a very, very important topic. And if you think about it, right from the start, we knew that people living in care homes were amongst the most vulnerable. And we did all that we could to support them. And we knew that because we know that COVID-19 has a bigger impact on people the older that they are. And so this was obviously a very important topic from the start. The clinical advice at the time had three parts. Firstly, that if you take somebody who's had a test, and given that it took about 4 days for the test result to come back, and they stayed in hospital therefore for those 4 days, that test could come back negative, but the person could have caught COVID in hospital in that time. And that's obviously bad for that individual, but it's also bad for the care home, because then they'd be going back to a care home with a negative test result.
Bear in mind, I think about a third of all deaths, I think occurred in care homes.
People thinking that they tested negative, but having COVID-19. Secondly, the biggest challenge in this space was that the clinical advice at the time was that if you didn't have symptoms and you took a test, then it was likely to give you a false negative result. And that clinical advice stayed all the way through this period and then was changed later. And then the third point is that the most important thing to do, which is what we did in the advice that we gave to care homes starting in February, is to make sure there's infection prevention and control in the care homes. And in fact, the data published since all of this has shown that the best estimate from Public Health England is that 1.6% of the transmission into care homes came through this route. And in fact, what that tells you is that, sadly, the biggest route of COVID-19 into care homes is through the community. It's through people who live in the community and work in the care home. And so the most important thing for protecting people in care homes was staff testing, which we introduced as soon as we had the testing capacity to be able to do so.
Well, certainly there seems to be a lot of confusion here as the allegations suggest that Public Health England advice was initially to test on discharge. And certainly, as we've heard, Mr. Cummings told this committee that number 10 had been specifically told that that was happening. So to clarify this, would you provide copies to this committee of all internal advice and communications between your department, Public Health England, and your ministerial team on hospital discharge and care home testing, certainly for the period from January to April?
I'm very happy to ensure that the clinical advice and the clinical testimony is provided to this committee. Yes, and in particular, if you actually look at the testimony to this committee about the commitments that I made, the commitment was that we would introduce this testing, and when we had the capacity to do that, given the other pressures on testing, which is a life-saving resource, we did that.
So just to be clear, you're happy to publish all clinical advice that PHE, your department, and your responses and your ministerial team's written responses to the committee, so that we can analyse the same?
Well, I'm absolutely happy to provide the clinical advice on which these decisions were taken, yes.
So not your responses, Mr. Hancock.
I'm sorry, I don't understand.
Yeah,
This
you do.
decision
So would
was...
you be prepared?
It's talking about the emails. Are you happy to publish? Excuse me. To publish the letters, to publish the emails. That's what you want to see, because that's the stuff that will reveal the actual logic and the thinking behind these decisions. The advice is crafted, but the letters and emails will reveal the actual thinking behind in the government at the time.
To publish your written responses to that advice and the written responses of your ministerial team, so that we can be clear on what direction public health officials were given?
Yes.
Thank you.
Oh, there you go.
Just on that point that Rebecca Long-Bailey raised, so she mentions what Rebecca's described as initial advice at the beginning of the pandemic, just before lockdown, which is the period we're looking at in this section. And that was signed off by two PHE officials, we're told, Dr. Moore and Dr. Verne. Will you provide the committee with that initial advice?
Well, I don't know anything about that advice.
Well, assuming it exists.
So, but I'm very happy to go away and look to see what advice was given.
And assuming it exists, will you provide that initial advice to the committee so we can compare it to the advice that was eventually adopted?
Well, subject to the normal rules of disclosure. So I'm cautious here, but I've got a reason for it, which is that there is in that period there will have been a lot of advice written that then goes through layers of clinical approval. And there will have been, so I don't want junior officials to end up having their material put into the public domain. But what I'm very happy to do is go through and look, especially if there is particular advice from these named individuals, and to make sure that that's provided to the committee.
Well, as you said in answer to a question just a few moments ago, actually transparency about the process of decision making. Everyone was operating, especially in those early weeks, in a fog of great uncertainty as to what was the right thing to do.
Yeah.
We're trying to learn lessons that might be applied later in this pandemic, but to other emergencies, as to what the right approach is. So what's obviously vital for that is not just to see the final products, but how the advice evolved.
Yes, and also the reasons for that evolution, because there will have been a debate about it, I imagine.
Precisely, exactly. So that, I think, is behind Rebecca's question. I think it's why it would be useful to see this.
Okay.
Thank you. Just in terms of those early weeks, and talking about taking clinical advice and following scientific advice, as you say, one of the clear things that's emerged from our oral hearings and the evidence that we've had is that clearly we didn't lock down early enough. Neil Ferguson suggested quite a lot of lives would be saved. I think he said up to half of those initial deaths if we'd locked down a week earlier. The whole question of the changed advice in the middle of March reflected that. And again, this is something that I think has pretty clearly emerged. And some people said there was a degree of groupthink around this. From your position, did you not see that for all of the kind of complex modelling, that actually the mathematics of this pandemic were pretty stark? That you have, say, 60 million people in the adult population. If 2/3 of them contracted COVID and 1% of those who contracted it died, we'd have 400,000 deaths, and that is unacceptable and liable to overwhelm the NHS. How did we, and you in particular, alongside everyone else, miss this for so long, for about 6 to 8 weeks?
Well, I would absolutely say that we knew about this problem from the start. And the challenge in those early weeks of March was making a massive judgment, probably the most significant judgment that any Prime Minister has made, certainly in peacetime, based on incomplete information at a great pace. So I instructed the department and the health system to plan on the basis of a reasonable worst case scenario in January, in fact on the 27th of January. And I asked for a reasonable worst case scenario planning assumption. And I was given the planning assumption based on Spanish flu, and it was signed off at Cobra on the 31st of January. And that was a planning assumption for 820,000 deaths. And I was determined that that would not happen on my watch. So throughout February, we were planning for how to stop that and how to deal with the consequences of if it came true. And in the middle of February, the scientific advice confirmed that the reasonable worst case scenario should be taken as read, that this was equivalent to Spanish flu. I mean, if you think about it, at the time, at the end of January, when that was first presented at Cobra, I, like everybody else, thought of Spanish flu as something you read about in the history books. But as health secretary, you're always worried about new pathogens. We're dealing with them all the time. But knowing that that was the reasonable worst case scenario, we planned for it. And then we did the work in February, and on the 3rd of March, I set out to Parliament our, what we call the action plan, which set out all of the actions that we might have to take, up to and including shutting schools. I was asked about on the media about it, about lockdowns, and confirmed that we would be happy to take those.
So all these steps, all these setting out, that was the planning phase, and then we set out to Parliament the plans that we might take, including the one that makes the difference. It's all these steps. So he's talking about a month of planning there.
Time on the 3rd of March when we set that document out, setting out all the things we might have to do and saying that we were prepared to do them. There were no deaths. Indeed, on the 3rd of March, there were 50 cases.
We'll never know. We'll never know that because we weren't testing for it. How could we possibly know that there are only 50 cases in March? And how can he say that at this committee, knowing that the testing capacity was nil? It doesn't make any sense to me. Hopefully somebody will question that point.
Beginning the 9th of March, what happened is that the data started to follow the reasonable worst case scenario. And by the end of that week, the updated modelling showed that we were on track, essentially, on the track of that, something close to that reasonable worst case scenario. I think the numbers were slightly below that, but they were of a scale that was unconscionable. So we then, therefore, on the 16th of March, when there were 611 cases and 53 deaths, we took the decision, we announced that everybody in the country should stop all unnecessary social contact.
So we know what happened, and we've got a clear view. It's all in the public domain, but it's evident, and everyone agrees. Sir Patrick Vallance said it would have been better if we locked down earlier. Neil Ferguson, I mentioned, said that it would have a big reduction in deaths. We didn't do what was necessary early enough, and it seems to me that everyone, or certainly most people in the system, got bogged down in the modelling and the complexity, and didn't step back to see the crude maths of it, if you like, and to take the measures that were eventually imposed earlier. And in trying to learn lessons and thinking back, you were someone that was involved in all of those discussions. How was it that you, but everyone else, didn't see the enormity of what was going on and took these literally incremental decisions to turn up the dial progressively week by week in terms of restrictions? Why did we miss the big picture?
Well, the clear scientific advice at the time was that there is a need to have the tools like lockdown at your disposal, but also that the consequences and the costs of lockdown start immediately. And critically, the clear advice at the time was that there's only a limited period that people would put up with it,
right.
would put up with lockdown.
And so
now that proved to be wrong
Quite.
because the British public have stepped up to what we've asked them to do in an extraordinary way.
So much of that proved to be wrong. It proved to be wrong that people would only tolerate the restrictions for a short period of time.
Obviously.
It proved to be wrong that the level of infection could be contained within the NHS until that had to be revised. We're aware of that, and SAGE got it wrong. It's now very clear, and members of SAGE are candid enough in the way of scientists to concede that, and this is what we're trying to learn.
Yeah.
Was it the case that you simply accepted that scientific consensus without challenge because that was their business? Were you concerned about it yourself, and did you challenge it? Or did you think it was not your place to, you were there to enact
Dramatic
what
bell.
was being recommended?
No, we absolutely debated and challenged that advice. But when you're faced with a decision of this
I'm guessing
enormity,
that means that.
and ultimately, of course,
Right.
as Health Secretary, my primary goal on protecting lives, finding a way out of this and protecting the NHS, I made that argument. But ultimately, we didn't know how long people would put up with it. And now it seems obvious that people would put up with lockdowns. It was not at all obvious. We needed the protections in place, especially for vulnerable people in the shielding programme. We take for granted that has been a huge success, but that wasn't clear at the time because lots of people rely on social contact literally to live. And we needed to ensure that we could, for instance, support businesses to get through this. These are huge decisions. To take those decisions against the scientific advice is an even bigger decision to take. Now, when the scientific advice moved, then that became easier. And I remember when
But do you regard it as part of your role to challenge that scientific advice, to debate it, to stress test it, to ask others perhaps around the world?
Yes, and of course.
And
I was discussing this with my counterparts across the world, and I'd been willing to overrule the scientific advice earlier. For instance, on quarantine, I pushed in January for a wider flight ban from China, but the scientific advice was we should only restrict it to Wuhan. So absolutely, challenging the scientific advice is one thing, but overruling a scientific consensus is much harder, especially when the costs of the lockdown are immediate and are obvious. So I remember very, very clearly when the new projections from SPI-M came in towards the end of the week, beginning the 9th of March, and I can't remember exactly what day it was, but towards the end of that week, SPI-M came in with some new projections. And I remember going into number 10 and one of the most senior advisors saying to me, sort of ashen face, "Have you seen these new projections? Isn't this awful?" And I said, "I'm glad the projections are now showing what I think is happening." Because the data, you've got to remember, let me take you back to what it was like. The data was so incomplete and sparse. Even getting data out of the hospital system was very difficult. And we now have infinitely better data systems than we did.
So how did you form this view of what was happening?
Because I could see from what I was seeing on the ground, I could see from anecdotes from what I was hearing. You could see it in the testing data, the testing numbers going up. You could just see it in the number of people, sadly, who were dying, but the numbers were still very low at that stage. As I say, on the 16th,
and that's the advantage of being health secretary, that you're literally visiting hospitals, you're talking to people.
So then I remember the moment around the cabinet table when I said, we are going to have to tell everybody to stop all social contact.
Right.
And I remember thinking, this is the most extraordinary thing that I've ever said. And the Prime Minister said, yes, we are. You better go and tell him.
So as it turned out, what you just said there is pretty much identical to what Dominic Cummings told the committee, that he had come to believe that there was going to be a disaster and that the assumptions that the policy was being based on were wrong, but that he felt intimidated. He didn't use that word, but what he said in multiple answers said that he felt very reluctant personally to intervene, to overturn what had been an established consensus. And that's am I right in detecting in what you've said a similar thought?
I just think it's hard when there is a clear scientific advice to go against that with a decision of such enormity. And there's one other example that I wanted to set out. Maybe now's the moment to do it, which is about asymptomatic transmission. Mm-hmm. So one of the big reasons that we changed policy, for instance, towards care homes in April, was because of the conclusion that there was significant asymptomatic transmission. Now, there was a global scientific consensus based on decades of expert work on coronaviruses that coronaviruses do not transmit from people who don't have symptoms. And this is wrong, but it's wrong because this is a novel pathogen, it's a novel virus, it's unprecedented. I heard evidence from China that there was asymptomatic transmission in January. And I also remember talking to my German opposite number, Jens Spahn, and they had seen some evidence in Germany. And I asked the scientists to look into this. And in fact, I was so worried about it, I arranged a call with the World Health Organization. And I was told on that call that with respect to China, this was likely a mistranslation.
When was that call that you made?
At the end of January. I can get the exact date.
You'll have a transcript of that.
We have a note of the meeting, yes, and I'm happy to supply that to the.
So in the process of throwing the
I was
World
told
Health
that it was likely
Organisation
a mistranslation.
under the bus.
And after that, we did not get the evidence from China
Excuse me.
which could have proved it. So I was in a situation of not having hard evidence that a global scientific consensus of decades was wrong, but having an instinct that it was. And I bitterly regret that I didn't overrule that scientific advice at the start and say we should proceed on the basis that there is asymptomatic transmission until we know that there isn't, rather than the other way around. But when you're faced with a global consensus and you don't have the evidence that you're right and this scientific consensus is wrong, it is hard to do that. And eventually, on the 2nd of April, the World Health Organization was still claiming that there was no evidence of asymptomatic transmission. It's the 2nd of April. Now, on the 3rd of April, the CDC came forward with an evidence paper, and very shortly afterwards, Public Health England came forward with a further one, and the consensus scientific position changed, and then we brought in the stronger. We changed a number of policies across government as a result. Okay. But that is a story of how how preparedness and relying on the science, which is normally the right thing to do, and let's be clear, we're picking on two areas where there was where it would have been better if the prevailing consensus at the time had been overruled, but everybody was operating on highly sketchy, just a lack of data and a lack of information because this is a novel virus.
Well, what you said about the difficulty of challenging a consensus, a scientific consensus, is very frank, and I think it's very helpful for us to reflect on. And we've heard from other people variations on that theme. But since you raised this question of asymptomatic transmission as not being known and knowable, you said you had an instinct, but the science was against it. It is the case, as you'll be aware, in the SAGE on the 28th of January, the second SAGE meeting, in the minutes, point 16, it says there is limited evidence
Yes.
of asymptomatic transmission, but early indications imply some is occurring.
Yes. So I raised the prospect of asymptomatic transmission on the 27th of January with the CMO and others. And he took it away and they discussed it at SAGE on the 28th. And I called the WHO on the 29th. And I've got the quote here. I was told that it is highly unlikely it was highly likely that the message may have been confused via translation issues, but that this is unclear.
Okay, but SAGE on the 28th of January
Yes.
concluded that early indications imply some asymptomatic transmission is occurring.
Yes, and the overall scientific...
So SAGE did not... So in the minutes of SAGE, it was not recorded as saying the consensus is that there's no asymptomatic transmission. Quite the opposite. They're saying early indications imply some is occurring.
But the World Health Organization advice and the clinical advice that of the most likely situation that I received remained that asymptomatic transmission was unlikely. And in fact, the WHO's position was that, and I quote, there has been no documented asymptomatic transmission. Now, as I say, given all of this and this debate, and it's an absolutely accurate reflection of the debate, I regret that I should have stuck with my guns and said, well, there is, even if it's uncertain and even if it's relatively small, we should base policy on that, because even though the advice, the formal advice I was receiving was that it is asymptomatic transmission is unlikely and we shouldn't base policy on it, and that was and I should have overruled that.
Well, this is an important point, and you
Yeah.
mentioned the WHO in that, and you said that the WHO view on the 2nd of April, I think you said, was that asymptomatic transmission was not to be assumed, was not a possibility. But in fact, the WHO on the 2nd of April, in its situation report, said, and I quote, transmission from a pre-symptomatic case can occur before symptom onset.
Yeah, and so we had this position where there was this essentially there were individual instances of the evidence being presented, but the overall scientific conclusion, which was the recommendation for the policy advice, was that it was highly unlikely there was asymptomatic transmission.
Well,
And
that's
so,
a strange thing to conclude, because SAGE on the 28th of January said early indications imply some
I know.
asymptomatic transmission. The WHO on the 2nd of April said for transmission can occur before symptom onset. So there certainly wasn't a consensus. There might have been mixed messages, but not a consensus.
well,
that
there was what I can tell you, and I can send you the details, is that the clear overall clinical advice was against this, despite the fact that that I raised it from the start, and there were individuals in the system who were pushing this argument, and there were individual conclusions. But if you look at the totality of the evidence, then this was the position. And as I say, I wish that we had that I'd stuck to my guns at the start.
Well, we'd be grateful for that advice, and it doesn't stand against your conclusion that, as you've just said, it would have been better if we had assumed asymptomatic transmission, even to the point of you stepping in and overriding the assumptions that some other people were making. Just finally, and then we'll turn to the next theme of our questions. We heard, as I'm sure you've seen reported from Dominic Cummings, that during this period in mid-March, when the penny was dropping, that we were on the wrong track and needed to change, the Deputy Cabinet Secretary, Helen McNamara, came into number 10 Downing Street and, according to Mr. Cummings, said, "This country is heading for a disaster. I think we're going to kill thousands. There is no plan for this. We're in huge trouble." Was there a plan?
Yes, and at that point we had published it.
So Helen McNamara was wrong, or do you think she didn't say that?
I have absolutely no idea. But what I can tell you is that we'd published the action plan of the actions that we might need to take, including these extraordinary, unprecedented actions. And the question was when to make the judgment to do it, when to put in place, if it was needed, a lockdown, closure of the schools, etc.
And so Ms McNamara or one of her colleagues hadn't communicated to you her concern that there was no plan?
I don't recall having any conversations with her at that time.
Or any of her team of officials?
Well,
obviously you had a conversation, but to that effect, to raise the alarm that there was no plan.
I don't understand that testimony.
Okay, all right.
I also note that no evidence has yet been put forward for much of this testimony, and I find that telling.
Indeed, and it's part of the point of asking that question is to see whether your recollection tallies with what was said, or you've been clear about that. Well, that brings then this section of the hearing. I'm going to hand over to my co-chair, Jeremy Hunt. We'll suspend the sitting for about 5 minutes while we just change around.
Okay.
So order.
The proceeding is currently suspended. The proceeding is currently suspended.
About the test and trace programme, Dido Harding was appointed on the 7th of May, and I want to specifically look at the question as to why that test and trace programme, when it was set up, didn't prevent a second or third lockdown as we had hoped, and indeed as test and trace programmes managed to in other countries. So with the benefit of hindsight, this is a looking back to see what we can learn going forward. Why do you think it was that that test and trace programme didn't prevent further lockdowns?
Well, I think the number one challenge that we had was going into this without a large-scale testing programme, as we discussed in the previous session. And we had a small, effective, but not easily scalable contact tracing programme. And putting those things in place at very large scale is hard. So we needed somebody to who had experience both of building big retail organisations and of the NHS and healthcare, and there was nobody better placed than Dido Harding to do that. As I said earlier, I'd taken on essentially, executive authority to make it happen, but I had a lot of other things that I needed to do. In fact, one of the things we did during this whole period was we brought brilliant external people in, Paul Dighton on PPE, Kate Bingham on vaccines, and others. So the starting point is that building a plane in flight is harder than flying a plane that's been built for a while. And that is central, I think, to some of the areas where this country found it more difficult. Next thing is making sure that we had a system that was rigorous enough, was critical. And we built that over time. And there were improvements that we had to make as we learned. So, for instance, one of the changes that we made in about September, October, was that if you were phoning somebody up on the contact tracing side to an individual, you asked them to tell their contacts in their household to isolate, instead of asking for the names of all those individuals and then phoning them one at a time. That change increased the efficiency of the system enormously, and was something that we had to improve. So when you build a huge system that I think Baroness Harding has said that it was about the size of Tesco and she built it in 6 months, there's constantly things that you have to learn on the way through, whereas if you start with the system, then it's got all those teething problems ironed out.
So do you think, 5 months later, on the 7th of October, after it had been set up, SAGE said that test and trace at that stage only had a marginal impact on transmission. At that point, and recognising that huge improvements have been made since then, but at that point, was that a fair assessment?
Well, I think that was probably at that point a backward-looking assessment, because by that point we had a very large system.
And it was a fair assessment of what had happened to that point.
It's SAGE's assessment.
But is it yours?
No.
So you think they were wrong on that one?
I think that it had an impact, but it clearly hadn't had an impact big enough to bring R down from the R0, which is the R in the natural state of around 3, down to below 1. Now, there is evidence now, as of today, that the surge testing and tracing and isolate system that we've got in place is working. If you look at the case rates now with the Delta variant, the places where over the last month we've put them into surge testing, starting with Bolton, but also true in Bedford, in Hounslow, and other places, their case rates are coming down.
I totally accept that, and it's fine to mention it, but I'm really looking specifically at why we didn't manage to stop a second and third lockdown. So I take on board what you said. I just want to go through, if I may, some of the other reasons people have suggested as to why test and trace wasn't as successful as we'd all hoped. Now, you said earlier this morning that one of the reasons was that by the time we set it up, we already had around 2,000 cases a day, which was much higher than the levels that test and trace was having to cope with in Korea and Taiwan. So that simple scale was one of the reasons. Another reason that people have suggested is because people who were asked to isolate by test and trace didn't actually do so. Now, in February of this year, Baroness Harding gave evidence to the Science and Technology Committee, where she presented two bits of evidence. One that said that 20% of people weren't fully isolating when they were asked to. Another that said that 40% weren't fully isolating when asked to. Do you have a more up-to-date number as to what numbers of people more recently are fully complying with the isolation requests?
I don't have an up-to-date figure. I'm very happy to write to the committee with whatever we have. I'm afraid I didn't prepare on topics on that topic. But what I would say is that we can see it working, and since Baroness Harding said that in February, we've done two important things. One is that we've strengthened the isolation payment so that in the targeted areas, anybody earning less than 26,000 gets the £500 isolation payment. So we've strengthened that element of it. And the second thing is we've increased the size of the isolation assurance service, which is the team of people who phone up and knock on the doors of those who are meant to be isolating to make sure essentially that there's stronger enforcement of isolation.
Thank you. And that's, I think, very welcome news. But I think the very specific thing we're trying to understand, because this is a lessons learned exercise, is why in that middle period of last year we weren't successful in preventing the second and third lockdowns. And when Baroness Harding gave that evidence in February, we were in the middle of our third lockdown. Now, just on that point of financial support, some people say that one of the reasons people didn't isolate is because we didn't just give a simple promise that if you isolate because you're asked to by test and trace, we will make up, as the state, any salary loss that you have. Would that have helped?
Well, the challenge that we had with that proposal is the extent to which it might be gamed, because after all, a contact gives test and trace their contacts. That is what contact tracing is made of. And so you wouldn't want a situation in which you, if you tested positive, you could then list your entire friendship network who all get a £500 payment. So,
but that friendship network
salary
would be more reassured, and you might have been more willing to give their names if you had known that any salary they lost in the 10 days or 2 weeks they were asked to isolate was going to be made up. And just with the benefit of hindsight, I appreciate not all these things were known at the time, but is that something we should have been more open to?
Well, I think it's fair to say that I'm glad that we've made the change now.
Okay, I think we can interpret from that perhaps what your private position is. But I just want to go on, because there were lots of other reasons that were put forward. And one of them was that we didn't have enough involvement early enough of local authorities in the contact tracing side. And indeed, some people argued in the testing side as well. Now, we know that they've been very involved recently, so I don't want to use the recent examples. This is simply about that period in the middle of last year. But knowing what we know now, Do you think there is an argument that someone is more likely to comply with an isolation request if they're called up by someone locally, who can then potentially check up locally, rather than someone in the call centre 300 miles away?
Well, of course, and the fact we've changed it to have that dual approach is testament to what I really think. Now, because I think that is the best way to do it. But if I can just explain for the record, since this is a lessons learned exercise, some of the reasoning. So you have to have the national and the local system. And we know that because internationally, where systems are local only, we know that when there's a serious outbreak, they get overwhelmed. So I remember distinctly a phone call with my Spanish opposite number, in which I said, and tell me how your test and isolate and tracing system's going. He said, oh, it's terrible. It's fallen over in, and then he named a number of parts of Spain. And I said, and what about the national system? He said, no, we have no national system. So in countries that had only a local system, they pined for a national system. In this country where we had an essentially national system at the start, the critique was you need more local engagement. The honest answer is you need both. And this comes to data flows. Data flows have been strengthened enormously in this last 18 months. All the way through from the dashboard that the Prime Minister and I look at most days on what's happening, through to the management information that the department has about the whole health and care system. You'll remember from your time in the department that getting data out of the NHS used to be a huge struggle, and we now have common dashboards that we look at, making sure that there's free flow of data between organisations in a way, of course, that protects privacy, but allows for decision making and allows for targeted activity, for instance, between local and national. This is absolutely critical. It's been improved no end, but by God, was it a problem at the start? Absolutely it was.
Okay, but I think we can understand now that you would need some national contact tracing capacity for surge capacity.
Yes.
But would you say, looking forward, that the primary engine of contact tracing should be local, with national surge capacity ready to step in when necessary?
I think that's simplistic. So the way that we've tried to optimise it is not just according to surge and therefore the scale of need, but also according to those who are being contact traced. There are some people for whom a national call centre system is the easy way of most efficiently gathering the data quickly and then acting on it. So speed matters here, and a national call centre system can be much faster. And then you need the local boots on the ground, especially for the hard-to-reach cases. So what we've put in place is a system that is as smart as it can be, and it's improving all the time, on optimising which case and which positive goes through the local system, which goes through the national system, and when. So if you can't reach somebody after a number of calls, then it gets switched to the local system and they can send somebody around to knock on the front door. But you wouldn't put all contacts into the local system straight away because you need to essentially deal with the easy to reach, which can most efficiently be dealt with nationally. So it's about optimizing a joint system with data flows that are unhindered and a team who work together cohesively. That's the way that I think this is best done.
Okay, and then just a final reason that some people say we may have still had those very large numbers of people who weren't isolating when we need them to, which meant that we couldn't prevent those second and third waves, is that perhaps, again looking back, we were shooting for the wrong target. The whole system during last year was geared around testing targets. First 100,000, then 500,000, then 1 million. And sure enough, if you give a big system a target, ultimately they hit it. But shouldn't the real target in a pandemic not be a process target like testing, but actually the proportion of people who you need to isolate, who actually do isolate? Do you think, looking back, we hit the target and missed the point?
No, because we absolutely had those targets for the number of people who isolated and the number of people who we successfully contacted. We publish as much of that data as we can. The challenge in running a very large system is that if you have a target that is only indirectly reachable, you also need goals on the way that are process targets that are measurable. And so the answer is both. And if you think about it, just one more comment on this, we learnt a huge amount from this experience that I've just described of improving the contact tracing and testing system for the vaccine rollout. So on the vaccine rollout, we have local and national data integration. We have the local systems going and finding people who are hard to reach. We have the national system for the big numbers of people who are enthusiastic and willing to, drive and queue up. And that integration is something we actively took from the learnings from the test and trace system and ensured that it was embedded in the vaccination system from the start. So, we've been doing our own lessons learned all the way through this, and one of the lessons is this data integration and ensuring that you get the right activities happening at the right level.
Thank you. Greg Luck.
Thank you. I'd like to go into a bit more detail on the question of care homes. We know, and I think we've agreed already this morning, that the decisions, especially in the early days and months, are taken in a kind of fog of war. Urgent decisions have to be taken without all of the information. But that fog is dispersing, and some things are becoming clear. And I think it's fair to say that during this inquiry, we've established pretty clearly that we were too late to lock down sufficiently vigorously, and that many people, Sage, Dominic Cummings, yourself, everyone agrees that if we'd either known more or perhaps acted earlier, then that would have been better. I think we've learned that, and we've also established that we had inadequate testing capacity during the early phases of the pandemic. Both of those prospective conclusions, ones that you would agree with.
Well, I think that I absolutely agree that if we'd had that greater testing capacity at the start, of course it would have been better. But I'm a practical man. We didn't. My job was to build it,
absolutely.
not just to feel sorry for myself that we didn't have it. We had to get on with it.
Absolutely, and we want to be practical and to learn lessons that can be applied in future. So what I want to establish here is whether we should add a third of these lessons, which was that discharging infected patients into care homes was, and for many perhaps understandable reasons, was one of the major faults in the first steps to handle the pandemic. You said, Secretary of State, right from the start, we've tried to throw a protective ring around our care homes. What was that protective ring?
Well, I think the most important words in that sentence are that we tried to. Mm-hmm. It was very hard. And all of these deaths in care homes, each and every death in a care home weighs heavily on me and always will. And we knew from the start, from very early in January, that the impact of this disease was most significant on the oldest, and therefore care homes were going to be a particular risk, care home residents. And this was a problem that we had across the whole of the UK, and indeed there were some other countries that had really difficult circumstances. And so we put in funding. We made sure PPE was as available as possible. It was a challenge because we didn't have a distribution system. We had to build one. And we set out guidance for care homes. First guidance was on the 25th of February. And then later, when we had the testing capacity in July, we brought in the weekly testing of staff, which is, I think, the single biggest improvement in terms of protecting residents. And now, of course, we put care homes, both the staff and residents, in the top priority for vaccination. So that's what I meant, but it was very hard for a number of reasons, some of which are fixed and some aren't. So, as I am Secretary of State for Health and Social Care, yet at the start of this pandemic, the powers I had over social care were extremely limited. The formal powers rest with local government, and formally social care is a responsibility of local government, but I feel it keenly. We didn't have the data. When I first asked for a list of all of the elderly care homes, we didn't have one, which I find totally extraordinary saying, but it's true. We simply didn't have the levers, and we had to invent a whole series of them. We now have far better data. But some of these problems still need to be fixed. We need to reform social care, and we need to make sure that we put into law the ability of national government, where necessary, to come in firmly to whether it's to issue guidance or that's binding, or put in place funding, because we had to funnel funding indirectly through local authorities as well, because we had no varies to fund local care homes directly. So there's a whole series of things that have been improved, and then there's a whole series of things that we still need to do.
So let's go into some of the decisions, and to know whether you did have levers yourself or whether you were denied them. We know that on the 17th of March, NHS providers were instructed by NHS England, and I've got the letter from Sir Simon Stevens to all NHS trusts, ordering them to urgently discharge all hospital inpatients who are medically fit to leave.
Yes.
Obviously a very famous instruction.
Yes.
Was that a unilateral instruction on the part of Sir Simon Stevens and his colleagues at NHS England, or was that, as it were, a kind of co-decision that he took with you?
No, of course that decision was discussed with me and the Prime Minister before it was executed. And if I take you back to the time, we just had the scenes from Lombardy showing what happens when a health service is overwhelmed. We knew that the death rate would increase dramatically. We didn't know how much, but dramatically if NHS services were not available. And we needed to make sure there was NHS capacity, because the number of cases was going up at the time exponentially. So we protected the NHS, and one of the things in the lessons learned exercise, which is really important for us all to remember, is that whilst there were absolutely challenges in some areas, there were some things that this country got right, and the provision of care at all times to COVID patients is one of them. Now, that instruction actually led to a reduction in the number of people who left hospital and went to care homes, because the vast majority of people went home to their own homes, and we put in place social care packages. Because one of the other things that we did as part of that decision was we agreed to pay for the discharge. So in normal circumstances, when you leave hospital, the local authority has to arrange the social care package, and sometimes individuals have to pay for that, and sometimes the local authority does, as you well know. Because the central government, through the NHS, decided to, and the Treasury provided the budget to pay what's called discharge to assess, to pay for those discharges, it meant that we could get discharges, more of them, to people's own home. And in fact, one of the reforms we need to make to social care is that more people should be discharged to their own home with a care package as a proportion than into care homes. So the result of that letter, ironically, and I know it's counterintuitive, the result of that letter was a reduction in the proportion of people who were discharged into care homes. Now, I'm sure we'll come on to the testings around them, and in fact, we've already discussed it to a degree. But yes, that letter was a policy that was agreed at the highest level in government.
Absolutely, and that's very clear, and that's very helpful. And you've also said in that answer that the motivation was a concern, looking at Lombardy, that the hospitals might otherwise be overwhelmed, and that galvanised the action that was a reflection of.
Yes, but I don't want to imply, and it would be wrong to conclude, that that's because we somehow favoured the need to protect the NHS. Because as well as the scenes from Lombardy, I still remember, and it's burned across my soul, a news report from Spain in which the military were sent into care homes And in one particular case, the care home had been abandoned because the staff were ill, and all of the residents had died, all of them. And many had died from COVID, but many had died because they needed care in order to live. And there were care homes in France where every resident died as well. And so this was a problem that everybody struggled with, and we talked about it amongst my colleagues across the continent, and of course with my fellow health ministers across the UK, how best to protect the most vulnerable. And in fact, in England, the proportion of people overall who died, who lived in care homes, is lower than in many European countries. So yes, this was incredibly difficult, but I think it is. You've got to look at the whole picture, and the number one fact, if you like, that matters in this is understanding how COVID gets into care homes.
Well, we'll come on to that, but the motivation you said was to certainly protect the NHS and avoid a Lombardy situation, but you've been very clear that was not, did not mean that you were unaware and unconcerned at all about what was
on the contrary
to care homes. You said that very clearly. So is it the case that when you had that discussion with the Prime Minister about what I guess was the proposed advice from Sir Simon Stevens at that
Yes.
point, were you clear that the testing capacity to test people leaving hospital going into care homes would not be there immediately and for at least a number of weeks?
Well, I don't recollect directly, but I know for a fact that the testing capacity at that time on the 17th of, well, the letter was, I think it's dated 17th of March. Well, I know at that time that the testing capacity was around 1,000 a day, because the 17th of March was the date on which we had the cabinet room meeting where I took direct personal charge of the testing
knew
system.
that there wasn't the capacity there to do it, but did you communicate that to others that were part of the discussion about this new policy?
It will. I'd be amazed if that wasn't part of the discussion. I haven't seen the minutes of that discussion recently. In fact, I don't think I've ever seen them. But but I know that it was agreed and signed off across government. There is no doubt that the testing capacity would have featured, but also remember that the clear clinical advice at the time was that testing people asymptomatically might lead to false negatives, and therefore was not advised and was seen as not a good use of the precious few tests that we had at that moment.
I mean, this is an important point of contention in our last evidence session, as you know, because the evidence that we had from Dominic Cummings was that people in that meeting felt assured that the testing capacity would be in place. Now, at the opening of the session, when I put this to you, you said you were always clear in your mind, and as far as you know, the way that you communicated this, that you were talking about a plan to get to that capacity. Is there, thinking back, was there any possibility for ambiguity there? Do you think in that discussion you could have
Okay, folks, cheers for being patient with me there. And jump back into this.
And in terms of the numbers here, in your initial answer, you talked about the numbers. How many people were discharged before testing was available for people being discharged?
I don't have that figure with me. I think it's in the public domain, and if it's not, I'll get you the best estimate that we have.
Right. I think the NAO says it's about 25,000. So you presumably
I wouldn't dispute the
you wouldn't
NAO
dispute the
figure.
NAO. That reflects your feeling.
I wouldn't dispute that figure.
Okay. Now you did say that the number of discharges actually going into care homes fell compared to the previous year. I think I remember you saying that.
The figure I actually used was that the proportion of discharges fell.
The proportion. And is that from that NAO analysis? Is that
that's from an NHS analysis that I think we published at the time. But if we haven't published,
right,
then I'll make sure we get
Well, I think it is the same analysis, and that talks about a period between the 17th of March and the 15th of April. But it misses out a crucial period at the beginning of March, in which it was the case that actually the number of people being discharged from care homes was higher than it was in the year before. Were you aware of there being an escalating problem that required you in the middle of March to put the brakes on it?
Well, I wouldn't be surprised, but the recollection I have of that chart, if you like, of that data series, is that it was essentially flat and then fell. The proportion of people who were discharged into hospital, and you can see a clear policy reason why that would change on and around the 17th of March, and that's because we put the funding in to fund the NHS to buy the care packages, which are more likely to be the care packages in people's own home. But I'm sure that we'll go through the full detail of exactly what those numbers are.
So in terms of the steps that were taken, you said that the transmission into care homes was not predominantly from people coming out of hospital, but it was from staff. Is that right?
So Public Health England have made a recent publication of this, and they've found that approximately 1.6% of the cases going into care homes came from people leaving hospital. And there's two reasons that it might be so low. The first is that, of course, there were infection prevention and control, essentially isolation rules around how people went from hospital into care homes, because of course they were not tested, because the testing capacity wasn't there, and the advice was not to test for the reasons I've set out. And therefore, there was already an isolation process in lieu of knowing whether somebody was COVID positive or not. And anyway, if people were COVID positive, there needed to be an isolation arrangement for them. The second reason is that just in terms of the numbers, the proportion of people who go into a care home is much, much higher each day from staff. That's inevitable in any care home. The number of people who are residents who move in and out of a care home on a daily basis, even in normal times, is a fraction of the number of staff and indeed other professionals like like GPs and other health professionals. If you think about a care home and who physically goes in the door, the number of times that person going through the front door is a resident is really quite a small proportion of the total. So I do understand why people feel very strongly about this point of residents going into care homes, but in terms of the volume of human movement and interaction with a care home you can understand once you think of it that way, because this virus transmits between humans of whatever type, whether you're a staff member or a resident, the virus doesn't know or care. It's therefore the staff testing regime that was the big change that we brought in over the summer, and then we learned all of these lessons and did a review with the care home providers and CQC and others, and came up with the care home winter plan. And so in the second peak throughout the winter, the proportion of deaths that we've had in care homes is far, far lower, and that is part of, that's one of the many lessons that we've been learning as we go through this.
Well, let's go on to the staff transmission in a second. But on that Public Health England report, which I've read, essentially it relates a positive COVID result in a care home to whether that person has been in hospital before. That's the way that it's, I think they call it a data linkage approach. That's the way they approach it. That's right, isn't it?
Well, the methodology is the best methodology they have. It is a difficult figure to put a number on.
Yeah, but it's made more difficult, is it not, by the fact that people weren't being tested in care homes, and therefore the chances of finding someone with a COVID positive test and then linking that back to a discharge from the hospital is very low indeed, because the whole point that we've been discussing is that testing was not available in care homes. So isn't it, to put it most politely, a stretch of the imagination to believe that 1.2% of cases, 1.6% of outbreaks are attributable to hospital transmission into care homes, when we simply don't have the data because people weren't tested there?
Well, it brings me back to the central point about the challenge of responding to this pandemic, which is that we were having to make these judgments, sometimes very big judgments, based on imperfect information.
Absolutely.
And getting better information is vital. Now, I think that that study is the best assessment that can be made, given the fact that the facts on the ground in terms of what is and isn't measurable. So it's always a challenge to measure these things.
It is.
And estimates are estimates. I think I described it as an estimate rather than a fact, partly for this reason. However, once you think about the number of people who go into a care home and think about that in terms of staff and residents, you can see why that a figure of that amount or might be appropriate. There are reasons to explain it, but anyway, that is the best estimate that we have. But of course, it remains an estimate.
But that's a bit of a danger for a lessons learned inquiry for us and for you and colleagues in government in the department, because that study was a look back at what happened during the period. It was an attempt to learn lessons, and you drew a pretty important conclusion, which was that infections from hospitals was a small, in fact a tiny proportion of deaths in care homes. And that conclusion then has policy consequences, very important policy consequences for the future, to look, for example, at staff transmission rather than so much hospital transmission. But it's not possible. We don't know what the answer is, because people were not being tested in care homes. So it's completely impossible to say that less than 2% of infections in care homes were attributable to hospitals, is it not?
No, because firstly, we did test in care homes throughout when people were symptomatic. And then we brought in the Vivaldi study in care homes over in the late spring, after the first peak, but nevertheless we brought it in. And so this isn't based on no data, it's based on the data that we have. But I keep returning to this point that you're working on imperfect information. I also disagree with the idea that because that figure is low, therefore it shouldn't matter. It does matter. Each one of those infections matters, and so absolutely the discharge protocols, which require now testing and isolation in lieu of until there's a comprehensive test result, of course that matters.
But the care home providers are very clear. We all know that there was limited testing in care homes.
Yeah.
So to attribute the deaths, the positive cases in care homes to hospital discharges without a representative study can't have the weight that you're placing on it. We don't know, and it's important that we do find that out. No?
Well, of course, it's important that we find out as much as we can, but there are some things about that first peak that we'll never know because we didn't have the information gathering capabilities that we have now. So it's a but I also I will also argue, and I'll always believe this, that it's best to make your best assessment of these things, even if you have to recognise that these assessments are imperfect. I mean, the search for perfect information in a pandemic is a vain one.
Indeed, we should, and therefore, open these things up to scrutiny. So,
absolutely, like publishing the PHE report so that the chairman of esteemed select committees can read them.
Quite so. And has it been peer reviewed?
I don't know.
It would be normal for an important publication like that to be peer reviewed.
I'm sure it says it on the top of the document, but the
it doesn't even say who the authors are.
Well, I will. I'll go back and find out if it's peer reviewed. But we do look. We've also there is a different approach, a different principle that in a slightly different part of the forest. There is far more pre-peer review publication now, because you have to get the best information you have with all of the caveats, including the ones that we've discussed, out into the public domain, rather than waiting for perfect information which may never come.
A final question, which picks up on the point that you made about the possibility of infection from staff, social care staff in care homes.
Yeah.
You recognise that as an important potential source, but obviously the weekly testing of staff was not announced until July.
Yeah.
And I think was rolled out from July onwards.
Yeah.
Obvious question, why, if that was thought to be the prime way of infection getting into care homes, why was it not possible to do that earlier?
Well, again, this comes down to the prioritisation of tests.
Right. So you went as far and as fast as you could, given the testing capacity.
And given the clinical prioritisation of the use of tests, yes.
Right. So, in essence, what you're saying is that this question of infections within care homes comes from a combination of an understandable and perhaps necessary requirement to avoid a Lombardy situation in the NHS, combined with what we've previously talked about, which was an inadequate testing capacity. That is, that they're the components of the problem in care homes as you see it.
And a presumption that testing people who had no symptoms would lead to false negatives, which turned out to be wrong, but was the clear clinical advice for some time until we had a better assessment of that in April.
Thank you very much.
Thank you. Dr. James Davis.
Thank you, Chair. Thank you, Secretary of State. I'd like to return, if I may, to the success of certain countries in South and Southeast Asia, so South Korea, Singapore, Taiwan, and so forth. We've already touched on their pre-existing testing capacity.
That's becoming a real sore point for him, this idea of Singapore and Taiwan and South Korea testing. And he thinks he's cleared it up, but that's going to be the thing that dogs the government's COVID response throughout this and any public inquiry as well. This is going to be something that, because when you compare our response to those countries, it's dismal. And yes, SARS and MERS are different, sure, but those countries learned from SARS and MERS. We didn't even apply any of the same kind of logic to this. So it's not going to go away. And I'm glad this guy's focusing on it. It's the right thing to do.
Were you given advice not to follow their strategies in other respects?
No, I don't think we were advised not to follow their strategies, but I can't remember being formally advised to follow their strategies. But we did have discussions. With them.
Mm-hmm. And in retrospect, you would agree that there should have been more focus on what was going on in that part of the world and their success?
Well, there was a huge amount of focus on what was going on in China, although one of the things that hindered our early response was a lack of transparency from China, and that must be put right in terms of future preparedness for future pandemics. It is absolutely vital for the world that China is more transparent about its health information as soon as it understands that there are problems in future. With respect to the rest of Southeast Asia, I think that we would benefit a lot from ensuring that our future pandemic preparedness learns from the other from different strategies that were pursued right around the world. The strategies different countries pursued, in my view, followed essentially two things. One, their recent history, and the countries that obviously had, it's standard now to say that the countries that had experienced MERS and SARS were better prepared, partly because their body politic had had a shock a decade earlier, and here that shock in around 2009 was not heeded as much as it should have been. The second is in terms of their capabilities and, to an extent, their geography and history. So it is harder in a democracy to take some of the steps that some of the authoritarian countries took. Geography matters. So Britain is an island, and we have the benefits of being an island in terms of borders, but we are a highly interconnected island which has a tunnel, and a huge amount of our freight comes accompanied. So other islands like Australia, New Zealand, Taiwan were able to be more absolute at the border, whereas completely shutting the border here is not something that we are structured to do, because I think a very serious chunk of our daily imports comes accompanied. And then of course this history is also about the capacities you have at home, and we just didn't have the testing capacity in particular, and the contact tracing capacity that others had.
We didn't have the capacity, but was it discussed that British people wouldn't accept East Asian testing and tracing methods?
Well, there was a debate about how much people would accept it, but I was always of the view that people would go for it, and my view on the use of data was that because the mission and the motive was so important, people would be willing to allow their data to be used, and give consent to that because the justification was so clear. The story that I told at the time is, over 95% of people are willing to give their iris scan to the Home Office in order to have a queue that's maybe 5 minutes faster at the Heathrow when they go on holiday. And if you're willing to give your biometric data to the Home Office, you're likely to be willing to allow your data to be used to save lives and try to...
Short example, because nobody knows that data is then being stored in any way. You just think that you're going through airport security.
Stop a pandemic. So my view on the public's approach to consent for their use of data for these purposes is that my experience is that they are very enthusiastic so long as there is a proper mission, and there was a clear mission here. So I was up for action in this space. I personally didn't think that would be a problem so long as we articulated it properly, we got all the privacy rules, etc. right.
Mm-hmm. Now, Dominic Cummings alleged that there was a lack of urgency in our approach to the pandemic in February and March because we believed ourselves to be lower down in the pandemic curve. He also said that the implementation of measures was delayed because there was a lack of planning and preparations in place? And how would you respond to those 2 points?
Well, the first is true and the second is false. So it's absolutely true that we thought, and the advice we had was that we were earlier in the pandemic curve than our European neighbours, and we were, as it happens, we were seeded. The virus, we now know from genomic testing and the huge genomic testing capability we now have, that there were thousands of individual incursions right across the UK. So we didn't have an outbreak in individual areas. We had an outbreak essentially everywhere at once. And that was one of the reasons that we had a tougher first wave, along with frankly the fact that the population isn't as healthy, and we know that obesity is a significant risk factor. So that was true. On the second point, the idea that we didn't have a plan, the evidence I can best point you to is the fact that we had at that point published a plan.
Okay, fair enough. Finally, from me, in terms of face coverings, now SAGE discussed in late April the fact that there was some evidence, albeit weak, for the use of face coverings. Then I think on the 11th of May, they had issued advice for their use in enclosed spaces. Then the UK government mandated their use on the 15th of June in public transport settings, 24th of July in shops, 24th of September elsewhere. For the record, in Wales here, that was 6 weeks later, I think, for each change. But why was there a delay, first of all, in implementing what SAGE was advising, and also why were we as a country as a whole perhaps behind other countries in the world?
Well, there was a rigorous international debate about the use of face masks, and there were very significant divisions in the science on this. And I think that it is one of the clear lessons from the pandemic. It comes down to disagreements about the most likely route of personal transmission of the virus from one person to another, and there is now a common understanding much more about aerosol transmission from one person and how face masks are therefore more important than was the initial advice. There is also a practical consideration that we didn't want people to take face masks away from where they were absolutely vital within health and social care settings. And so when we did introduce rules around public's use of face masks, we introduced them saying that you should wear a face covering, as many people in this room are, because that way it didn't take away from the provision of PPE. Now that isn't a problem. We've got huge stockpiles of it, but it was a problem at the time.
Thank you, Chair.
Anam Kaiser-Javid.
Thank you, Chair. Thank you for joining us today, Secretary. So whether it's policy implementation or the general workings of the UK Government, or even in your role as Secretary of State for Health, public trust is of paramount importance. Getting those key lines right, ensuring that communication is clear and maintaining that trust so that the general public have faith in leadership of the country. Would you agree with that statement?
I very strongly agree with it, yeah.
So then why during the pandemic do you think that the Prime Minister had lower approval ratings in comparison to his counterparts of devolved nations?
Well, I don't think it's about approval. I think it's about, as you say, public trust. And we worked very hard to ensure that we had the support of the public. And in fact, when you look at the proof point of that, the consequence of that, the public have been incredibly strong in supporting the measures that we asked them to support. And ultimately, that's what you need the trust for. And then perhaps the most important factor when it comes to having the trust of the public is to make sure we get very, very high vaccination uptake. And we've got extraordinarily high vaccination uptake. That is, and that's true across the whole of the UK. In fact, I think it's stronger in some parts of the UK than others, but this isn't a competition. It's important that that's high everywhere.
Okay. But going back to that idea of how the public view their leadership, that is something that is taken into consideration, whether that's by the media or by government or by other members of the public. In November, an Ipsos Mori poll found that 74% of the Scottish public believed that Nicola Sturgeon had handled the pandemic well, in comparison to 19% who thought the same of Boris Johnson. Now, there could be differences there because the NHS in Scotland is devolved and there's NHS Scotland. But what lessons do you think the UK government are learning in terms of their communication?
Well, I don't have the latest figures on me, but I noticed that to prove your point in your question, you picked figures from November, and I've already said that I think that the operation of government has improved very significantly since November, and the public have definitely noticed that. And in fact, the public trust across the UK in the measures that the government have taken has increased significantly. I've noticed as Secretary of State that it is now more efficient, more effective, there's better communication inside of government, there's a better sense of teamwork, and that is so important in a pandemic. And the public have undoubtedly noticed this improvement over the past 6 months or so.
Do you think that the public trust you?
Well, I
as
think
Secretary of State?
you can judge that you can judge that for yourself. And
I'm asking you, what would you?
Well, I think all I can say is that the approach I've taken throughout this is to try to answer questions as directly and straight as possible. I'm a big team player. I'm willing to say difficult things if necessary, and that is I think the best approach you can take in the pandemic, answering difficult questions and answering the questions that are easier to answer. You know, when difficult things happen, my approach is to go to the dispatch box or have a press conference and explain why there's a difficult thing. And I think that's important in a pandemic in particular. But at the same time, I'm a huge team player, and I think it's very important that we operate as best as we can as a team.
Yeah, and I completely agree with you. Team player and ensuring that all four parts of the UK are heard loud and clear. Rewinding back at the session that we had with Mr Cummings a couple of weeks ago, he claimed, whilst I was questioning him on borders, that the Prime Minister in the UK government prioritised the economy over people's lives. Now that's quite a damaging allegation, but that allegation was made. I'm not going to question you on the validity of that, but what I'm going to ask you is, statements like that have been made, what actions are the UK government going to take to maintain or regain trust from the public?
Well, the honest truth in response to that is that we have some of the toughest border measures in the world, and people can see that we're willing to take difficult decisions on borders based on the data if that's what's needed. So, for instance, just last week we had to remove Portugal from the green list of countries, despite the fact that that was very uncomfortable, and there were lots of people who were on holiday or out in Portugal on business, whom that had a significant impact on. But when the data changes, then we are willing to make those difficult decisions because we have a tough approach at the borders.
And you think those decisions are made in a timely manner?
Well, absolutely, yes. In fact, when we took Portugal off the green list, I was criticised for acting too quickly. But when you see
very evasive body language there, looking away. Let's see that again.
Based on the data, if that's what's needed. So, for instance, just last week we had to remove Portugal from the green list of countries, despite the fact that that was very uncomfortable, and there were lots of people who were on holiday or out in Portugal on business, whom that had a significant impact on. But when the data changes, then we are willing to make those difficult decisions because we have a tough approach at the borders.
And you think those decisions were made in a timely manner?
Well, absolutely, yes. In fact, when we took Portugal off the green list, I was criticised for acting too quickly. But when you see a new variant, then it's incumbent to act.
Okay. Many ethnic minorities during the COVID pandemic have sadly passed away. What steps did your department take to engage in those communities who, for example, maybe have English as their second or third language, or traditionally don't engage with the NHS?
Yes, this is incredibly important throughout. To be honest, I think it's something that we have got better at. We've got better at working alongside local authorities in terms of engagement, and we've taken those learnings, a lot of which we learned through the use of the testing programme, and deployed them in the vaccination programme. And although the vaccination rates now are lower for some ethnic minority communities, we are seeing those rates rise up, which I'm really, really pleased about.
Sorry, the question I asked was what steps did your department take? So yeah, you're saying you worked with local authorities.
Yes.
Anything else?
Yes, huge amounts of work. I mean, both.
That's what I'm asking.
So for instance, the Minister, Nadine Zahawi, on the vaccine rollout has undertaken a huge amount of work over the last 6 months in terms of engagement with communities of all sorts across the whole country, whole of the UK, to make sure that we try to get the messages across. For instance, ensuring information is available in the language that people commonly use is so important. And from a point of view of the attitude that we take, some people say you've got to do better at reaching hard to reach communities. I don't think about it like that, because that implies that somehow it's their problem. It's about making services more accessible to people and making sure that we make it as easy as possible to access services. Because I'm pretty sure that you've got to make sure that you reach out. So that's been a big part of the plan all along. Okay,
and just one last question. So Mr. Amjad El-Hilrani was an ENT specialist at University Hospitals of Derby and Burton, and died on the 28th of March 2020, and he was the first doctor to die due to COVID, and a lady called Nasreen was one of the first nurses to pass away, sadly. And you're sitting here with your NHS badge on. It was one of the first things I noticed. Do you think NHS have trust, or NHS staff have trust in yourself and the government and the way that you've handled the pandemic, and will lead us out of the pandemic?
Yes, I do, and it's something I put a lot of effort into. And right across the UK, making sure that the health services we provide are there for everybody is incredibly important.
Those questions aren't particularly material, so they're very easy to evade. Somebody just asks you, do you think that people trust you? Yeah. It's an easy one, isn't it? As for the other things, he obviously couldn't set out a clear direction or clear steps that the government had taken to work with ethnic minority communities. It's most likely that he doesn't know. And that's rather unsurprising as well, considering the shortfalls that we usually see between the government and those communities. Providing guidelines in common languages people use, as he put it, is very vague. Be interesting to see if he's got more detail on that, and see if this lady here presses him further.
To me, and the NHS across Great Britain is our most valued institution, and the people who work in the NHS work incredibly hard and have faced some of the toughest situations of their lives over the last 18 months. It saddens me enormously that around 1,500 people from health and social care lost their lives in this pandemic. And I know, in fact, I know that the first 4 doctors who lost their lives were all from ethnic minority communities. In fact, I went at Eid, I went to Brent Central Mosque to thank them, and through them, everybody who works in the NHS from all different communities, and especially to mark the sacrifice of those who've come to this country to offer their services and to work in the NHS, and who gave their lives in that service during the pandemic. It's something that's moved me a lot.
Yeah. So would you say that you protected the NHS staff?
Alright, so at first glance, this seems like a nice thing that he's done, but I kind of pull back and I think to myself, because 4 doctors from ethnic minority communities died whilst treating patients with COVID in hospitals, he went to a mosque to thank everybody for their sacrifice. So, is everyone the same? Does everybody know each other? It reminds me of Trump talking to a black reporter at the start of his tenure and asking her if she could communicate a message to the Black Caucus, because they all know each other. But I mean, this is the tactic, isn't it? You go and visit a very symbolic place for a press opportunity, and obviously he's very relieved to be able to look back at that and bring it up here at the select committee, as evidence of him caring in some form. It's not material though, is it?
Absolutely, we did everything we possibly could, and not only that, but we protected the NHS, so the provision was there for patients as much as was possible, and we provided that the PPE, as we've discussed, and we worked together right across the UK, including with the Scottish cabinet member for health, Jean Freeman, who I worked very closely with, to make sure that everywhere in these islands people got the support that they needed and the treatment that they could as much as possible.
And Secretary of State, in the Chamber on Monday this week, you said that nobody was denied treatment for COVID. People got the treatment they needed. You repeated that earlier.
Yes.
I'd just like to draw your attention to 2 things. First, the widespread reports of the use of do not attempt resuscitation notices, which I know has been challenged,
Yes.
but was widely reported both last year, this spring, and is reported again today in the Telegraph in terms of people with mental illness and people with a learning disability. The second point is the refusal of some hospital trusts to admit COVID-19 patients from care homes. Bearing those 2 things in mind, are you really still saying that everybody with COVID-19 got the treatment they needed?
Yes, that is the medical advice that I have, and I totally agree with you about the inexcusable nature of any attempt to use do not resuscitate orders without consent, and when there were concerns raised at blanket consent being put in place, we stopped that immediately. So yes, I mean, making sure that provision was there was absolutely critical, and we did succeed. It wasn't just, it wasn't me on my own. It was a huge team effort that everybody was involved in, because part of the action that we took to suppress the virus was in order to protect the NHS. If you think about it, my strategy through this was to suppress the virus until a vaccine could make us safe. And I always believed a vaccine would come through, and I drove that project hard. But yes, the clinical advice that I have, and I checked again on this recently, as I said earlier, was that provision was always available.
But I had cases of this happening to a constituent of mine. I had a case on April the 3rd of a constituent in a nursing home. Her daughter was contacted out of the blue by an NHS hospital staff member who told her that her mother would not be admitted to hospital if she contracted COVID. Now, that was a battle that I took up on her behalf with the local hospital. But my constituent said this: my mum's life was made insignificant because she is old and has had dementia. Now, I understand from a colleague that this also happened in Hove and Portslade, and as I've said, it's still being reported. In my view, this was a serious impact of the policy of discharging patients from the NHS to care homes. In my view, it led to a mindset in parts of the NHS that it was okay to deny treatment to vulnerable and older people. Let me ask you, were you aware last spring that some hospitals had gone out to care homes and told them they wouldn't be admitting their residents?
I immediately insisted on the issuance of very clear and strong guidance, which is that this approach is completely unacceptable. It's never been acceptable. It's never been policy. And when I heard reports, and in fact you've raised reports with me of this before, I immediately took action to reiterate the position that do not resuscitate notices require informed consent. There are proper procedures around how you can go about giving and recording that consent, but individual decisions must be made on an individual basis.
Indeed. I really want the question, though, why we kept having reports, why this kept on happening, why there were patterns of this happening up and down the country, and we're still getting reports of it. There have been a couple of surges of reports of do not resuscitate nurses for people with learning disabilities, and the Telegraph includes today reports of people with mental illness. It certainly happened in parts of the Northwest. For people in care homes, and that was reported to me, and I've reported it in the House. Why were questions not asked about a policy with such wide-ranging impacts on vulnerable people? I understand it's been challenged and you put guidance out, but it kept on happening.
Well, the guidance we put out was absolutely crystal clear, and this the idea that a DNR notice should be put on without the individual consent process and the individual knowing what, being able to, the correct decision being taken with clinical advice on an individual basis it is completely unacceptable for the guidance not to be followed. And in a system as big as the NHS, it is very important that when people see problems like this, then they raise them and then we can address them. But the availability of treatment was always there. Treatment was available for these people in all circumstances, because we never ran out of that capacity, in part because of the action that we all collectively took.
So you're not willing to accept from these reports, and in fact, for myself as an MP, that this was happening, that there was a denial of treatment to some people. I understand, and I've said that you challenged it, but the problem is it carried on happening.
Well, I have seen these reports, and it's totally unacceptable.
How can you stop it, though? It's not as if it just happened once.
The strongest thing I can do is ensure that the NHS issues guidance to make the rules around this absolutely clear, and that is what I have done. The point about protecting the NHS is that the capacity to treat all people for COVID was always there throughout, even in the highest peaks. So that treatment was always available at all times, and I'm very proud that we managed to build that capacity. And in fact, the NHS themselves did a remarkable job in building the Nightingale hospitals, for instance.
Yeah, indeed. It's not about that, though, Secretary of State. It's not about that. It's about a cast of mind, a mindset that treated vulnerable people, people with learning disabilities, people with mental illness in a particular way. But let's leave the point now. I want to raise the question of expert advice to the government. You mentioned earlier clinical advice on testing on discharge to care homes, and you said it was advice from SAGE. I think you've quoted that a couple of times. SAGE had almost 100 advisors, including experts from health, epidemiology, criminology, psychology, statisticians, environmental and behavioural scientists, but no social workers and no input from care providers. Care England told me planning prior to the pandemic didn't involve social care, it was all focused on the NHS. The Association of Social Work Chief Executive, Dr. Ruth Allen, said, SAGE would be strengthened enormously by input from social work, and it is shocking that we have none. Some of the biggest care home operators have said that they repeatedly warned in March 2020 about the dangers of discharging people into care homes without testing. And they warned both you directly by email and via representatives of Care England. Given the terrible excess mortality in care homes, partly driven by actions that the care sector had warned could be damaging, you recognise that this failure to include expertise from the care sector was a mistake?
Well, the way that clinical advice reaches me as Secretary of State properly is that the Chief Medical Officer, who co-chairs SAGE, listens to the scientific views, because SAGE is a scientific body, and then also takes into account the operational considerations from social care, from the NHS, and from others, and then puts an assessment and recommendations to me and to other ministers, including, of course, the Prime Minister, and the Chief Scientific Advisor.
Do you think that advice was strong enough? Do you think that listening to the care sector was strong enough? Because I have to say, right through the pandemic, but particularly in the early stages, there was the view that care sector was being treated as an afterthought.
Well, I do think that we strengthened the way that we got advice from the care sector through the pandemic. And when we wrote the winter plan and published it, I think in August 2020, we took...
That's the second time that he's used that language of, I think we strengthened it, I think we got better at it, which is basically we were shit at it and we didn't do it well enough.
Several weeks to ensure that we worked closely with the representative organisations of the care sector to make sure that winter plan was road tested with them in advance, learning as many lessons as we could. But
was in August. That was not in March, April, May, June, July. That was in August.
Thank you.
So well past the first wave.
Thank you. I was coming on to that. Before we had then over the summer the time to be able to write a draft and then to be able to circulate it, take on board comments, which is the normal way, of course, of developing policy within government. In the first peak, we were operating with these huge decisions based on, as I've said, imperfect information, but also at remarkable speed. We had to move very fast. So, of course, we took on board views of the care sector and the experts on social care who we were engaged with, but we were not able to undertake the full public consultation that we normally would do with development of policy of this significance, simply because of the time that it took. And so, if you think back to those times, it was a matter of acting as fast as we could to keep people safe, and that meant that you couldn't go through the normal formal channels of consultation that you would for something obviously of this huge significance.
I think what's important, though, in terms of the lessons learned that we're trying to gather today, just the point about what impact this lack of knowledge about the care sector had on the decision making of the time. We had Professor Whitty say to the Health and Social Care Committee in July that the risk of agency staff travelling between homes and spreading the virus was not recognised early on during the outbreak. He admitted that in retrospect it's obvious, but it was not obvious early on, which really does show that there was no input, no listening, no expertise from the social care sector in that early stage, which was so important because, of course, decisions were being made that caused the excess deaths. Let me just remind you of this. My colleague Peter Kyle raised this issue, this set of issues in the House at PMQs on the 25th of March, and he wrote a letter about it to the Prime Minister, and he copied you on March the 31st. He described a care home in his constituency with a serious COVID outbreak involving residents and staff, making clear the staff who had COVID were agency staff who had been working in other care homes. I wrote a letter to you on April the 1st, jointly with John Ashworth, pointing out the lack of PPE in care homes, concerns about care staff unable to access tests, the need for testing for patients being discharged to care homes. I also raised the issue that care homes had said they were unable to transfer sick residents to hospitals due to a lack of beds, and that hospitals would not admit patients from care homes. Care England have told me that at the start of the pandemic, several care providers offered brand new care facilities that hadn't been commissioned and could have been used for the isolation of patients potentially with COVID discharged from hospital, and they received no response from the government. Having no expertise on social care in your group of advisors, why did you not heed the warnings about dangers to the care sector raised by MP colleagues, the care sector and Public Health England?
Well, you didn't only raise these concerns in a letter to me, you also raised them with me in the House of Commons. And I think making sure that we got feedback from MPs who are expert in particular areas, including in social care, was a critical part of the response. And it led to us strengthening the guidance throughout. So in that period, after you wrote on the 1st of April, I think it was, we strengthened the guidance to care homes on the 15th of April. So we had the attitude, and I remember discussing it in the House of Commons, I think in an exchange with you, Chair, the other Chair, with the member for Tunbridge Wells, for the record, about attitude to listening to concerns and the need to constantly feed that into how we responded. I was completely open about that. And so you raised the issue of care homes in the House of Commons, and we took into account those concerns as we updated the guidance, but it was inevitably an iterative process because we were operating at such pace in the face of unprecedented circumstances.
Earlier you said on your discharge policy to care homes that tests took 4 days to turn around, at which time a patient could have contracted COVID. But on the 11th of March 2020, the NHS said approximately 1,500 tests are being processed every day at PHE labs, with the great majority of tests being turned around within 24 hours. So that's 1,500 a day, with most turned around within 24 hours. And as I just want to reiterate the point, Care England has told me that several care providers offered the use of those brand new care facilities that hadn't yet been commissioned for use to isolate discharged patients. They received no response from government. Why?
Well, I wasn't aware of that letter, and on the turnaround times, what matters is
you weren't aware of the. Could you just be clear about this? You weren't aware of the offer from several care providers of care facilities that could be used to isolate patients, because that's actually pretty important.
Well, I can't. I think a better answer is that I can't recollect that letter. And what I can tell you, though, is that the turnaround times sometimes were fast, but sometimes not. And if somebody is left in a hospital setting when they've been tested, they can catch COVID. And sending somebody into a care home with COVID with a negative test result is very dangerous.
You're repeating a point that you made earlier, and I'm repeating. Care England have told me that several care providers offered brand new care facilities that hadn't been commissioned and could have been used for isolation. So if tests hadn't come back within 24 hours, they could have been used in that way. Could be in a combination of prioritising care home discharges to care homes for testing, and if the testing hadn't come back, they could have gone as an interim step to those care facilities which were offered. Why didn't that happen?
Well, as I say, I don't have a recollection of that correspondence.
Well, you'll admit that would have been a solution, though. And in fact, I think it was adopted as a solution later on in certain parts of the country that step-down facilities were used from hospital. But clearly, I mean, we're talking about thousands of deaths here in care homes. This is important. you were taking clinical advice on your policies that didn't include advisors from the care sector.
No, that's not quite right. So I just want to correct the point there, which is that the clinical advice, the scientific advice from SAGE, because SAGE is the scientific advisory group in emergencies, is then combined with the operational advice from the department and others in the clinical advice that comes to me. And I know that might sound technical, but it is inaccurate to say that because SAGE did not have operational experts, that therefore that was not taken into consideration in the advice to me. SAGE is a scientific body, not an operational body, and that's how the advice is structured.
It's a scientific body on whose advice you were relying for the discharge policy into care homes. Leave it there. You don't seem to want to accept the points I'm making. I mean, finally,
well, I just want to give accurate answers. Can I also add that on the point about, I want to add a further point to my answer on the DNRs, because I think this is such an important point. As well as issuing the guidance, we also asked the CQC, who regulate the care home sector, to make sure that they reiterated this point. And if there are further levers that are available to stop people wrongly using DNR notices, then I'm absolutely open to it. But I have sought to use every power at my disposal to stop the inappropriate use of DNRs, whilst allowing people who want to express a wish that they should not be resuscitated to do so.
Indeed. Just finally, before we leave this point about the lack of expertise from the care sector, or operational knowledge as you call it, you said earlier about the care sector, we didn't have levers, we didn't have data, we didn't even have a list of who the providers were.
Yeah.
I just point out to you that there are organisations like Care England and the National Care Forum that are perfectly capable of providing lists of providers, that are perfectly capable of advising the government. As I say, very strongly came across to me, both in my own constituency and nationally, that the care sector felt they were treated as an afterthought, and I think it would actually be advisable now to think about how to take their advice better into account so that we don't get into the decision making and the issues that we got to in this particular pandemic.
Well, absolutely, we were in contact with those organisations throughout, and indeed the CQC, but none of these lists are comprehensive, and this is the problem that we were facing, which we have now
You're
addressed.
saying that Care England doesn't have a comprehensive list of its members?
No, I'm not. No, I'm not. But I.
But we will definitely be making recommendations in this area in our report. So, Graham Strong.
Thank you, Chair. Can I just say, Secretary of State, I not always agreed with the decisions you've made in this area, but I do appreciate the number of times you present yourself onto the floor of the House of Commons and to these committees and other committees. Can I take you back about 2 hours, I would think, to Becky and Greg's questions, where they were asking about the information that they believed had not been presented yet when PHE changed their advice. Are you aware that a Dr. Cathy Gardner is taking the department to judicial review?
Well, the department is engaged in judicial review on a number of aspects.
Yeah. Because according to the Byline Times, which I think was what Becky was referring to, that report, you, or the department via you, had not provided the emails, advice and other information that had been asked for in that case. And I don't want to make a clever point, but if one was to apply to that lack of evidence the interpretation you put on Dominic Cummings not supplying us with the supportive evidence, then we should be very worried. So will you provide all that evidence that's been asked for in that case and has been asked for by this committee to the committee?
Well, of course, I'm happy to provide all the evidence that I've committed as per the previous exchange. But I'd say this: my whole approach is to provide you with whatever evidence is needed for you to reach your conclusions, and hence being open to questioning for as long as you like. I mean, and I'll tell you why, Graham, and it's kind of what you said about me coming to the House throughout the pandemic. I'll tell you why, and that's because I know deep in here that what I did and what my team did was what we believed to be the best thing we could on the information that we had to protect lives and to get us out of this pandemic. And we worked every day from the moment we woke up to the moment that we fell into our beds on that mission for months and months and months. And I know that I can face the mirror each morning, and despite my deep regret at the deaths that have occurred, I know that I did that with the right motive and being straight with people throughout. And this pandemic has caused enormous pain, but the way through it is to try to bring people together as a team, which I hope I've demonstrated, and be as transparent as possible.
I don't doubt your motivation, Secretary of State. I don't agree with some of the decisions you've come to. The membership of SPI B have given an apology for their advice. They said that they regretted having given extreme advice, and they thought that behavioural psychology had been undermined, that they had given too much bad news and not enough good news, and Gavin Morgan said he thought they'd not behaved ethically in doing that. Do you accept that apology, and do you accept any responsibility for the negativity and unethical nature of that advice?
Well, what I'd say is that I think that everybody who was in a position of responsibility in the health family was acting according to what they thought was their best interpretation of their role in helping the country to manage an unprecedented situation. And I just think that especially in a pandemic, when everybody is involved in trying to get through this, every single member of the public, everybody is involved. I see the best in people, and I think that the best thing is to try to motivate people to do their best in this common mission.
But what they were saying was that they'd exaggerated and cooperated with trying to create a climate of fear beyond the evidence. And I was just asking you whether you accepted that and you regretted the overemphasis on the negative.
But I don't think there was an overemphasis on the negative. There were thousands of people dying, and we needed to stop that.
Right. Can I just ask a couple of simple questions? One, you mentioned Portugal and moving it into the amber list, but there were other parts of the globe where there's virtually no infection. The best example I can think of off the top of my head is the Cayman Islands. Why weren't, as you were moving parts of the globe from green to amber, why didn't you move some from amber to green?
Well, the evidence is presented by the UK Health Security Agency, and the ministers then take decisions on the basis of that evidence. That's how we make the decisions between what's on the red, amber and green list. Sometimes there are balanced decisions when you could make the decision either way. In this case, the decision was it was very clear cut that we had to move Portugal off the green list, unfortunately. It gave me no pleasure to make that recommendation. and that's what we did. There are other balanced decisions that we will we'll keep looking at the data and make an assessment each time we do.
Can I ask a couple of questions about Greater Manchester and Bolton?
Sure.
I mean, Bolton has had both surge testing and an increased supply of vaccine, which is going to everybody, essentially. Everybody
who's eligible.
Yeah. Over Greater Manchester, there has also been an increase in infections, and Andy Burnham, the Mayor of Greater Manchester, has been asking that what has been given to Bolton is given to the whole of Greater Manchester. The surge testing, the support of the army is there, but not the vaccinations for everybody. Why is that?
Well, we have to make sure that we use the vaccines that we've got as appropriately as we can. I've been talking to the Mayor of Greater Manchester throughout this, and I'm glad that he welcomes the action that we've taken. It's clear that the package in Bolton has had a positive effect.
Yeah, absolutely.
And the challenge is that once you get to a much wider geography, including Greater Manchester and Lancashire, the more vaccination you put in, you've got to find those vaccines from somewhere. So we are working on what more we can do to get more vaccines into Greater Manchester, into Lancashire, to try to get the vaccination numbers up as well. But the immediate priority is to get as much testing done as possible so we can break the chains of transmission. Because you've got to remember that the vaccine takes several weeks to work, and not least because if you haven't had a vaccine at all, you need the second jab.
That sort of wonderful Radio 4 programme, more or less. I don't know if you ever listened to it.
A fine programme.
It is.
Now, what did they say?
They tried to understand why Wales is the country, not just in the United Kingdom, but it's comparable to any country in the world in terms of the number of vaccinations it's got out as a percentage. And the conclusion they came to was that they had stopped holding stock, and as soon as they got the vaccinations, they got them into people's arms. And England and Scotland and Northern Ireland don't seem to have been doing that. Is that not a solution to the Greater Manchester and anywhere else that's suffering increased infections? That the country stops holding on. There may be problems in the future in the supply line, but getting those vaccinations into people's arms is a good thing, as quickly as possible.
I'm grinning because I'm working out whether to give you the full answer, because I very much like my colleagues in Wales, and although we're in with different parties running the devolved administrations, running the UK government, there is a very clear answer to why this happened. And because you asked so nicely, I'm going to set it out, and then I will phone up my new Welsh opposite number afterwards. The reason is this, that we need to ensure that whatever happens in terms of security of supply, there is enough vaccine for people to get their second doses. So we ensure that there is enough of a buffer that we can be confident that people will get their second doses. Now, it's a judgment how big that buffer needs to be. Our colleagues in Wales, as you say, decided to hold no such buffer and go ahead on the presumption that supply would come through. But they also knew that if there was an interruption to supply, that England's buffer would be used to ensure nobody in Wales would miss their second vaccination. Now, that is not a decision.
Going to jump out here, folks, in a second. We've got a lot of the nitty-gritty, I think, and probably the big answers out of the way. He's been grilled repeatedly on multiple things. He's holding up all right. I've got to hand it to him. Maybe it's just because he's got a suit and tie. I don't know. Maybe he just doesn't look as dishevelled as Cummings did. But also, these points are going to be pressed to the government repeatedly. It's going to dog them throughout, as it should. These are the questions that need answering. Watch a bit more, and I'm going to jump off then. And then when I'm back on, I'm going to watch that James O'Brien video where he compares the answers between Cummings and Hancock and analyses that a bit. I'm sure that'll be hilarious.
I could make for England because I can't draw on anybody else's buffer. So I suppose what this demonstrates is that the value of the UK-wide vaccination programme and the fact that we've taken a UK, whole of UK approach benefits everybody, including in Wales. It enormously benefits everybody living in Scotland because we were able to procure on behalf of the whole United Kingdom. And I would argue that the vaccination programme demonstrates that the union saves lives, and in the case of Wales, the union has helped them to have one of the fastest vaccination programmes in the world, and I wish them every luck in the delivery of it.
Right, well, I hope you get on well with the Welsh. Go on. My final question, if I may, you mentioned at the start of the epidemic you had difficulty getting information out of hospitals, in particular to find out what was going on. It's been my experience as a Member of Parliament trying to get information out of NHS England that they have had a very tight control both on press releases and on the supply of information. They've played the information close to their chest. I have found that difficult, and I wondered if that was your experience in the elevated position of being Secretary of State. Well, have you always been satisfied they've provided the information?
You should ask the Chair his experience. The answer I'd give is that they are the supply of data, the use of data across the health family as a whole is infinitely better now than it was 2 years ago. And we have, through this pandemic, built a system of the provision of data for decision making across the NHS and PHE and the Joint Biosecurity Centre and the new UK Health Security Agency in order to be able to make better decisions founded on the best possible data science. I think that has been one of the benefits of the work that we've done during the pandemic, and so it is much easier now, and I pay tribute to the team in NHS England and across the department and the other parts of the health family for those who've pulled that together.
Thank you.
As you can see, I'm a positive team player, and what I can say is this is one that's going very much in the right direction.
Thank you.
Thank you. Dr. Luke Evans.
Secretary of State, my questions are around risk. What's your attitude towards risk?
Well, sometimes you have to take it, but if you take it, you should then try to manage it. To give you an example, we didn't know at the start of this pandemic if we'd ever get a vaccine for sure, but
damn it, Pico. The government really didn't help. Yeah, I agree. Are you in the UK yourself? It's kind of a shit show. If Boris cared about more people, he would have locked the borders. Yeah, exactly. And Hancock keeps saying that the government has the most robust border system out of any country, which is complete bollocks. And yeah, like give the NHS a pay rise. He sat there with his NHS badge. Hey, thanks for the follow. Appreciate that. Yeah, he sat there with his NHS badge and he's talking about, a lady earlier asked him if the NHS workers and NHS staff trust him. And he waffled on about how they've got, they've got their full support and how they got enough PPE that they needed. My mum works for the NHS, and yeah, God, I'm sorry to hear that it's been upsetting. Yeah, of course. The government thinks that they support key workers, and obviously they don't. It's all been, well, they failed them really, haven't they? PPE wasn't sufficient enough at all. I want somebody to ask him, and they haven't yet. I want somebody to ask him why private conversations with people like Dyson and other Tory donors basically were happening, where there was people who were producing PPE, offering it to the government, we know now, that were turned away. That's scandalous. Keyword support. Yeah, exactly. He's been grilled here to a certain extent, but a lot of the things he said can be demonstrated as false. Just looking at the stats that we have now and the reports that came out of the hospitals, nurses, and NHS staff like your mother were telling newspapers and speaking publicly about the fact that they didn't have the support that they needed and didn't have the PPE that they needed. The amount of cases that were in hospitals go to show that it wasn't the case. It is really just, it's fraud. This is the kind of, really, I worry that this is the largest amount of scrutiny that the government is going to have to deal with, and that when it comes around to the actual public inquiry, we're not going to see this level of questioning, because I think they're going to try and rush it through. They really don't have any kind of system in place to really question them. This is about as good as it gets for now. And I worry that, not enough people are watching this. And that I worry that when it comes to the public inquiry, that's just going to go under the radar. I'm going to watch a bit more of this as well. If you didn't catch before, I'm going to be jumping off quite soon. And then on the next stream, I'll look at other people's analysis of it, some maybe James O'Brien, and dig a bit more into it, because there's a lot to be kind of unpacked with it. Thanks for joining.
I believed that we would and could, and was willing to throw everything at it. And then we took risks, for instance, backing 6 different projects, even though only some of them have come off so far. And that was but then once we took the risk on those projects, we didn't just fire and forget and leave it. We then actively manage them. So you should take risks. It's one of the lessons of the pandemic that you need to take risks that are worth it, but they should be. I'm an optimist when it comes to making decisions like this, but I'm a rational optimist, and that means you manage risks as well as taking them.
You demonstrated that you said you put yourself on the line and put yourself in jeopardy with your 100,000 tests.
Yes.
But then at the same time, quarantine and vaccines, you've decided to keep some back as a buffer, and that's a conservative.
I quite enjoy that line of I'm a rational optimist. He's used a lot of emotional kind of language at various points. He said that line that he said before on the stand. He said it again here, which is about him waking up every morning, wondering how he can protect lives, or something to that effect. He's really trying to. He's tugging on the heartstrings when he gets the opportunity.
Approach. How does that pan out when we come to having the debate about the lockdowns?
Okay.
Because from your position, and you're sat in the cabinet, you've set it well, you realised, gulp, I'm going to have to set this out to the Prime Minister that we need to shut the economy. I'm interested to know what the flip side was.
Yes.
Because throughout this pandemic, Every measure
he
is
doesn't
about
care.
risk management.
Yes.
No vaccine is 100%, no test is 100%,
Yes.
no mask is 100%.
Yes.
It's how you stratify that risk.
That's right.
Could you talk me through the first lockdown, how that worked?
Yes. So epidemiology is a science of risks, and it is all about the balance of different risks, where the
sound is awful, by the way. There's some kind of drone in the background of this.
The typical projection of any particular figure is exponential in one direction or the other, and that leads to a particularly complicated set of metrics to understand in order best to manage. Now, fortunately, I'm trained as an economist, so whilst I don't have a clinical background, an economics and econometrics training, at least to the degree that I have it, it allows you similar training in the understanding of these concepts.
Really, really, really vague. Another really vague sentence there. Allows you training in these similar sorts of concepts. Basically, he's brought up the really sore point, which is he's not qualified to do his job. And I'm not sure why he's made the stupid move of reminding everybody about that, but he has. And yeah, I mean, and that's ministers in general. They don't have the training to do these jobs that they're awarded. Minister for Health, no clinical background. It is just a joke. Hancock is still lying there. Yeah, he shot himself in the foot. He's completely shot himself in the foot with that one. It's no point reminding everybody how unqualified you are to do your job. It's just
because for every measure ridiculous. We put in at the very start, we locked down the entire economy and switched off as only urgent care, and so all elective stuff was cancelled.
Yeah.
Rightfully so, for the capacity of what we've seen in Lombardy, you've set that out.
Yeah.
How did that change on the second lockdown?
Yeah.
Because you learnt the measures, you kept elective going, and there was a reduced impact on the economy. How were those decisions made at the top?
So, 2 answers.
Yeah, you're absolutely right. Millions of lives lost, and he says he's not qualified for his job. Yeah, exactly. And, he didn't cushion that by saying that he's studied things and learned things around it. He just pure up said that he didn't have a clinical background, which is, I mean, whilst it's honest, it's also shocking that that's his own view of his job as well. It just goes to show the lack of faith in himself and lack of faith in his position. Yeah, he's lost his brain. I don't know what he's doing, running on autopilot maybe.
Answers to that. The first is, the answer I just gave also comes back to the discussion we had about testing, because we had an exponential demand for testing, but only an essentially linear, we got it a bit above linear expansion of supply, and that's why we ended up having a shortage of testing at the point when the exponential curve got above what was essentially a straight line. And that's how it can be true that we continued to expand testing capacity and yet had shortages, because it's about the shape of the accelerating demand. When it came to the second lockdown, there's a similar way of conceptualizing this, which is that when case numbers are low but rising, you can see what is likely to happen but not certain. But when you bring in a lockdown that you have definite and immediate costs. And that makes for a difficult judgment, always based, of course, on imperfect information. So if I take an example for this, I know we're going to come on to the second lockdown later, but a really good example of this is the Kent variant, right? I remember having the meetings in November when we were under lockdown saying, something odd is going on in Kent. And I remember being on a gold meeting with Helen Whately is a Kent MP, and she was saying there is something happening in Kent and it's different. And we didn't have at that time an explanation. And in fact, I remember having a conversation with a member for Tunbridge Wells about there is something happening in Kent, but we don't yet know. And we then found out it was because there was a new variant that was more transmissible. Now, the challenge when it came to the action that we took in December was that we didn't know exactly what the problem was. We were acting with imperfect information, but we knew.
But with this, yeah, exactly, not the British variant, but the Kent variant. And now we've got the Boris Johnson variant, which he let in from India by not putting it on the red list early enough. I don't get this, because he's saying now, I think he's about to say, we've learned about the Kent variant and we've learned how it works, but they've literally just made the same mistake again with the India variant, or the Delta variant as it's now known. They haven't learned anything. I'm not sure what he's about to say, but they didn't learn anything from that, because they let another variant straight into the country again.
Even though, for instance, in Tunbridge Wells, even though the case rate was very low, we knew that if we locked down, that would have immediate negative costs. So you have an absolute and certain cost versus an uncertain but projected much worse alternative. And the balance of those is an incredibly difficult judgment to strike. And the conclusion I've come to, having been round this loop many times now, is that you have to act early and you have to act firmly.
So you have to act early and you have to act firmly. Surely, if I was sat there now, I'd say, so what happened with the India variant?
And there is and that's when you don't have the tool of a vaccine. Now we have a different calculus, which is that we have to offset that, what I think of as the 2020 dilemma. We now have a vaccine, and we know that we're in a race between the virus and the vaccine.
So that's why I wanted to pick up, and you preempted where I was going with this, because we've seen it 3 times, we've moved on.
Oh, is he going to touch on it?
And of course, there's an important day coming on.
Government acted to late close the borders. Yeah, exactly. And it seems like now the only reason he closed the border at the time was because he stopped wanting to travel to those countries himself, Johnson, that is, to have trade deals. And at that point, only at that point, it looks like, did he put countries on the red list. But it was already too late. The variants were already in, and we were already in this mess that we're in now. I hope this guy's about to ask about that.
The 21st, and this is about lessons learned. The lessons learned about the decision making, the economy versus the COVID health versus non-COVID health.
No, it's not.
And what happens to our freedoms on the 21st.
Yes.
How is that decision being come about? What's being put in to drive it? And what are the lessons that you've learned that you can take forward that we can put in our report for the next time should this ever happen in another 100 years?
So the number, sadly, I expect us to have a pathogen similar to this to deal with in less than 100 years, and we need to be better prepared. One of the things that can make the world better prepared is better data. So, the data, and I've complained many times in this session, explained many times that everything was based on imperfect information. And
it's all right to complain, Matt.
And that makes
shy away from
much
it.
more
You're allowed to
complain. But we have far better data now than we did. And we go through it each day and look at the trends. What we're looking at right now, the most important fact, is the link from cases to hospitalizations. And that link, the likelihood of a case turning into a hospitalisation, not the absolute of any individual, but the population-wide risk, that link is falling. And the question is how far it's falling and how fast. Hence we're watching the hospitalisation data like a hawk. Now, it is hard to work out that function, because there's a lag.
That guy's really missed an opportunity to ask him about the
as a former economic modeler,
very disappointing.
I'm sceptical of these models, but in looking through the model, it helps you to understand the data that you have. I think the decisions are best taken on the actual data that's in front of you, not necessarily the model, but a model can be useful to help you think about the likely future paths of the pandemic.
My final question to you, and I put it to you in the House a couple of weeks ago, about how rapidly this progressed. You were going to the G7 to discuss with the health ministers about a health surveillance and future plan.
Yes.
We do 50% of all genomic testing in the world on viruses. Is there a place for the UK to be leading that as a forefront, as a preservation plan for the future, so we have better data and surveillance to try and stave this off before it ever happens again?
There's no doubt that the UK has an important leading role in ensuring that we have better vigilance in the future. This vigilance needs to be not just on human health, but on animal health and the links, the zoonotic links between the two, and on environmental causes of...
He could have been reactive. He could have been reactive and said, well, you just talked about the Kent variant, and you said you've learned the lesson. Obviously, he hasn't. But he went on to the next pre-prepared question, unfortunately. So he's allowed Hancock to weasel out again. Yeah. Right, I'm going to jump off. Thank you everyone that's joined. Cheers, Dammit Pico, for the follow there. Hope you're well. I'm going to probably be jumping on tomorrow night when I'm going to be reading more from Akala, Natives. That fabulous book about British Empire's history and race in this country and how it all works. So take it easy until then. Stay safe, and thanks again for joining.